I, Dr. Padma Shri, take immense pleasure to welcome you all to the international webinar on optimizing pregnancy care series 4, presented by the Fetal Medicine Unit of Department of Obstetrics and Gynecology, Savita Medical College and Hospital, with new challenges and new opportunities. Light is considered as a symbol of auspiciousness, abundance, and dispels darkness surrounding knowledge. I would now like to request all our distinguished dignitaries for the day to please join us for the lamp lighting ceremony and a prayer song. கலை நிறை கணபதி சரணம் சரணம் கஜமுக குணபதி சரணம் சரணம் தலைவனின் நினையடி சரணம் சரணம் சரவண பவ குஹா சரணம் சரணம் சிலை மலையுடையவர் சரணம் சரணம் சிவ 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 சரணம் சரணம் உலவொரு மொரு வரை சரணம் சரணம் உமை சிவை அம்பிகை சரணம் சரணம் கலை நிறை கணபதி சரணம் சரணம். Now I feel greatly privileged to introduce today's resource person, our beloved Professor Siba N. Krubamani, for the welcome address. Ma'am hardly needs any introduction. She is the past president of Obstetrics Gynec Society of South India. She is a president of Chennai Menopause Society. She has won a lot of awards, including Lifetime Achievement Award in Tamil Nadu, Dr. MGR Medical University. She has also won the Dr. APJ Abdul Kalam Award in 2017, and she has written a number of textbooks, including handbook on USG for training MBBS doctors. She has also won a lot of academic awards and best faculty awards.
Badmishri, can you stop sharing?
Yes, ma'am.
Yeah. A very good morning to each one of you. It's a moment of pleasure to welcome on behalf of Fetal Medicine Unit, Savita Medical College. I offer my special welcome to Dr. Tony Tan from Singapore, a guest of honor who is dedicated fetal medicine specialist. Thank you so much, sir, for accepting our invitation. It's my immense pleasure to welcome a renowned speaker, Dr. Girija Ward, an extremely talented moderator. My warm welcome to eminent speakers, Dr. Malathi, Dr. Sudarshan, Dr. Kappahambal Sairam, Dr. Lakshmi, Dr. Prem, Dr. Deepthi, Dr. Selvakumar. This webinar intends to understand the USG screening and prediction so that we can optimize pregnancy care. So, this webinar will enlighten us and provide us with an approach to deal the day-to-day problem. I welcome each one of you, and I'm sure this is going to be a meaningful webinar. Yes.
Thank you, ma'am, for your thought-provoking address. The next is followed by the most awaited address by the distinguished guest of honor.
Can I have his CV, please?
Yes.
Yes. It's my pride, privilege, and honor to introduce Dr. Tony Tan, a consultant obstetrician and gynecologist. Put it in a slideshow. He's a committed fetal medicine specialist. He graduated from National University of Singapore and then specialist in OBG. He's trained in Queen Charlotte Hospital in fetal medicine, including twin gestation. He held consultant obstetrician gynecologist of fetal medicine in KK Women's Children's Hospital and at Raphael's Hospital. From 2019, he has his own clinic, Tony Tan Women and Fetal Clinic. And he has also been appointed as Medical Director, Algrimia Obstetrics Screening Center. He was past President of Obstetric and Gynec Society of Singapore, Chairman, Maternal Fetal Medicine Committee of Asia Oceanic Federation of Obstetrics and Gynecologists. He is a Fellow of Royal College of Obstetric Gynecology in UK and Academy of Medicine, Singapore, and member of Royal Australian New Zealand College of Obstetric and Gynecology. He is also an examiner of MRCOG examination and for OG training. I request Dr. Tony Tan to inaugurate the webinar and address the participants. Over to you, sir.
Thank you, Professor Hepsiza, for your invitation and your introduction.
Stop screening the.
Hi.
Yes, sir.
Okay. Yeah, thank you. Thank you for your introduction and your invitation. From what Professor Hepsiza has told me about your hospital, I'm impressed with the teaching programs and the various subspecialties in your medical college. Ultrasound scan was first used for clinical purposes in obstetrics in 1956, 65 years ago, in Glasgow by obstetrician Ian Donnell and engineer Tom Brown. Since then, ultrasound machines have improved by leaps and bounds. Younger clinicians are now better trained in obstetrics ultrasound. I remember as a trainee that my senior consultant was not able to use the ultrasound scan to determine whether the fetus was in breech presentation or cephalic. A lot of standardization in obstetric examinations have been done, and this is thanks in part to the work by Nicolaides of Fetal Medicine Foundation and ESWOG. And a lot of data is now available as pregnancy outcomes are known after a short duration of 9 months, making obstetrics one of the disciplines with the most clinical data available for almost any aspect of the clinical management. Yet obstetrics is also a very traditional discipline. Many of the things that are done long time ago are still being done now as these things work. We should all be very committed to evidence-based practice as the alternative is not tenable. This means that we have to keep in touch with the latest ideas and publications. This has become easier due to the wide availability of the internet, PubMed, and Google. But not everything that is published is right, and not everything can be implemented in every clinical setup. Some studies may also show conflicting results. However, as committed clinicians, we all need to be up to date with the latest evidences available in our field and the duty to implement as much of the evidence-based practices as possible. I suggest that you start with reading the practice guidelines of RCOG, ACOG, ESWOG, and to start implementing those that are easy to implement, and then move towards the things that are difficult to implement. If you try and implement one new thing a month in your clinic, after many months, many of the things that you do in obstetrics will eventually be evidence-based. It also helps you when there are medical legal issues, as Bolam test is based on the opinions of responsible bodies of clinicians, i.e. RCOG, ACOG, AICC, etc., and not based on what you learned from your professors 10 to 20 years ago. With that, I would like to wish all of you a very fruitful webinar today.
For the nice introduction. Padmashri. Can we move on?
Yes, ma'am. Thank you, sir. We are extremely privileged to have you here today. Without any delay, let's move on to the first session of the day, role of ultrasound in preeclampsia screening. I'm profusely elated to take this opportunity to introduce our chairperson, Professor K. Jayashree and Dr. G. Rohini. Professor K. Jayashree Srinivasan is the HOD of the Department of Obstetrics and Gynecology of Savita Medical College. She is the retired director in charge of IOG, past president of OXY, vice chairperson of IOG 2015, best outgoing student of Chengalpet Medical College. She has received Sir A.L. Mudaliar Traveller Fellowship, CS Don's Best Paper Award in AICOG 1991. She has received the Best Teacher Award of Tamil Nadu Dr. MGR Medical University and Lifetime Achievement Award from Chengalpattu Medical College alumni. Presented papers in national and international conferences, published papers in national and international journals, organized many workshops and conferences, given oration, keynote addresses, moderated panel discussions, and she has been in many lectures. Dr. G. Rohini is the Professor and Chief Department of Obstetrics and Gynecology at Savita Medical College, Chennai. She is UG and PG from Gandhi Medical College, Bhopal, and she has more than 25 years of experience teaching undergraduate and postgraduate students. She has published many papers. She is a good mentor, leader, and an inspiring personality. Now I request the chairpersons to kindly take over the session.
Morning, everybody, and greetings from Savita Medical College. Preeclampsia, I think this, hello, am I audible?
Yes, 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 yes.
Yes. See, preeclampsia is like God, the supreme power, because we can never find the origin. I don't think anybody is going to find the origin of it, and we are very strongly. Hello, am I audible?
Yes, can hear you.
Continue.
So the
Speak பண்றது வரணுமே. Speak.
hello.
Yes, ma'am. Audible, ma'am.
Can you please put on Malati's slides? Introduction slide.
Yeah. Yes, ma'am. My slides are. I'm doing slide sharing. Are you able to see it, ma'am?
Yeah.
Yes. So, good morning, chairpersons. Can you see the slides, ma'am?
Ma'am, 1 minute. Your introduction, Dr. Jayashree will be introducing you. Then you can have it.
Yes.
Okay.
It's my great pleasure to introduce Dr. Malati Prasad. She is at present the director, Trichy Fetal Medicine and Fertility Center. She has won so many awards, won the first prize for paper on fetoscopic skin biopsy and best paper in UFOXY. She is consultant at Maternal and Fetal Medicine, TFMC, Trichy. And she has a lot of publications to her credit. And the posts held are, she was the secretary, Trichy Obstetrics and Gynec Society, executive member of Imaging and Fetal Medicine Committee, FOXY 2019 to 2022, vice president, Trichy Obstetrics and Gynec Society, post secretary, IMA in Trichy Society. And now, preeclampsia, everybody is very anxious to find out the origin, just like God, still we are not able to find out the origin of God. We are still not able to get at the bottom of this problem. And we are trying hard to find out if ultrasound can give the solace. Now, Dr. Malati Prasad is going to talk to us about the ways in which we can predict preeclampsia, that is screening of preeclampsia using ultrasound. Over to you, Malati.
Good morning, ma'am. Good morning, chairpersons. A big presentation. After a long time, I think we're meeting on a webinar. Today, I'm going to talk on screening for preeclampsia. We all know that preeclampsia is a major cause of maternal morbidity and mortality worldwide and affects around 10% of pregnant women. And the global incidence of preeclampsia is 3%. So we need some prevention, management, and screening strategies to screen preeclampsia so that alternative management strategies can be carried out early in pregnancy. So we're going to see how to screen for preeclampsia by ultrasound and other maternal factors. So we know that the main multifactorial factor in preeclampsia is a defective placentation. There's the transformation of spiral arterioles starts in the first and second trimester of pregnancy, where the spiral arterioles dilate. So this is the main reason where we look at the preeclampsia. When this dilatation of the spiral arterioles does not occur, this is depicted in the form of the uterine artery pulsatility index, which is picked up by the ultrasound. So other multifactorial factors are the oxidative stress, autoimmunity, platelet and thrombin activation, intravascular inflammation, and endothelial dysfunction. But based on ultrasound, we can only pick up the defective placentation, which is depicted in the form of an increased pulsatility index. So some of the risk factors, just to brush up, is to look at the maternal age, the ethnicity, parity, looking for smoking. A complete medical and obstetric history is very, very important. A previous history of preeclampsia, family history of preeclampsia. I will show you the software which depicts you the risk for preeclampsia in the later slides. And the conception method is very, very important. And the metabolic risk profile, for example, the height, weight, BMI should be entered in the software to assess the risk for preeclampsia. History of diabetes, whether it's type 1 or type 2, and a complete cardiovascular profile should be taken in the history. So following the history, as a patient walks in, you have to do a measurement of the mean arterial pressure. We do the measurements in the left and the right and take the average of the two. And make sure that the patient is not crossing her legs so that you get the correct depiction of blood pressure. And following that, we do a placental risk profile, which is first the uterine artery Doppler and followed by the serum screen. So why do we do the uterine artery Doppler? Why have we picked up the uterine artery Doppler and not any other vessel to look for preeclampsia? The rationale is that we know that the uterine artery is a sum of the resistance of the placental perfusion, and the uterine artery gives branches like spiral arterioles, which undergo a lot of trophoblastic invasion in the first wave and the second wave, and the spiral arteries dilate in a normal pregnancy and causes a decreased pulsatility index. When there is a defective placentation, when there is an incomplete transformation, that is, the spiral arteries do not dilate, they remain constricted, causing decreased uterine placental blood flow, which is depicted in the form of the increased pulsatility index in the uterine artery. So that is the reason we have picked up the uterine artery, because it gives you the sum of the resistance of the placental perfusion. So once again, defective placentation, there's an incomplete transformation of the spiral arterioles, which causes increased resistance in the uterine artery flow. When you have an increased resistance, you have an increased PI. When you have a low resistance in a normal pregnancy, PI is low. And there's because of this incomplete transformation of the spiral arterioles, which is depicted in the uterine artery pulsatility index. So this uterine artery pulsatility index is good for picking up severe preeclampsia and early preeclampsia, but less significant for late preeclampsia, because late preeclampsia, I think, is easy to manage because the patient comes in at 34 weeks, 35 weeks, you deliver the patient and patient becomes all right. So we are more concerned about the early preeclampsia rather than late preeclampsia. And histological abnormalities are more in early preeclampsia and less important in early onset preeclampsia. So what is the recommendation? What do we do? As Professor Tan said, it's important always to stick to guidelines because it helps you medically, and always you teach the right things to the students. The first and foremost is we do a Doppler examination of the uterine arteries at 11 to 13 weeks of gestation. That is, the patient, when she comes for a nuchal scan, you have to do a examination of the uterine arteries. Can be done transabdominally or transvaginally. We prefer doing it transvaginally because easy to maneuver, get into the uterine arteries clearly. And the detection rate will be based on the uterine artery pulsatility index. If it is more than 95th centile decay, we say that it is an elevated uterine artery PI. So the detection rate is 50% of early preeclampsia, which is a very good percentage, and 25% who are likely to develop preeclampsia with a 10% screen positive rate. So this test is able to pick up almost 50% of patients who are likely to develop preeclampsia. So based on the screening, we will do some management strategies. So which Doppler index do you do? We do the pulsatility index. Why the pulse index? Because of the fact that when there is an absent, that is when there's no diastolic flow, the PI will never reach the infinity because it includes a mean. Whereas when you check the resistance index or the systolic S bar D ratio, when you have an absent diastolic flow, you get an infinity, which is not possible. So the pulsatility index should be used for assessing the risk of preeclampsia. So uterine artery notching is seen in 40% in first trimester, not very specific. It's got a very reduced specificity. But 2008 meta-analysis indicated that increased PI or combined with notching is the most important predictor, Doppler predictor for preeclampsia. So we are all convinced that we have to do uterine artery PI in the first trimester of pregnancy. So how do you do it? I'm just giving a short video clip on how to do it. So first and foremost, get at the mid-sagittal section of the cervix where transvaginal approach. And why the transvaginal approach? Because it's easy to access the uterine arteries and the high velocity blood flow along the side. When on either side of the cervix, when you apply the color Doppler, you will have a high velocity flow. Apply the pulse wave Doppler gate. Make sure that the gate is not more than 2 mm. If you do a pulse wave Doppler less than 2 mm, you're likely to have a alteration in the pulsatility index. And incination angle should always be less than 30 degrees. And this very important factor is that the peak systolic velocity should be more than 60. If you have a peak systolic velocity of less than 60, it means that you're sampling some other vessel. You're not sampling the uterine artery. If you have less flow or you have more than 120 or something, you're sampling some other vessel and uterine artery is not sampled. So make sure it is more than 60 centimeters and make sure that you have at least 3 identical waveforms in a uniform pattern. So the pulse wave Doppler gate is placed on either side of the cervix. Adjust the incination angle and you get 3 waveforms, which is measured. You get the pulsatility index, which is done by autotrace in the ultrasound machine. So when you do it, you have to do it on either side. The left and the right should be taken and you get the mean pulsatility index, which is taken into account. So once you've done a uterine artery PI, what are the factors which are causing variations? One is uterine contractions. Any changes in the maternal heart rate. Suppose you have a maternal heart rate of more than 100, you're likely to have changes in the uterine artery PI. So take that into consideration. Ethnic origin and BMI is very important. That's the reason when you do a complete evaluation risk assessment as per the FMF software, you have to do a BMI aggregation. Increased PI is seen with decreasing BMI and because of the vasodilatory effects of estrogen. And previous PI also will cause an increased PI. So since maternal factors can influence the uterine artery PI, the maternal factors inclusion is very important. I will tell you, I'll show you some examples of how you should do it. So then anything more than 95th centile, when you have a PI of more than 95th centile is considered to be elevated. In a transvaginal approach, when you do a combined, so for example, you have 1.5 in one side, 1.5 in the other, you get a 3. So transvaginal approach, the 95th centile is equal. Okay, so anything more than 95th centile, we say that it is abnormal. It has got a sensitivity of 27 to 30% and 60% requiring delivery before 32 weeks of gestation. So it's a very good predictor of early onset preeclampsia. So this is not the right way of doing a uterine artery PI because you're sampling the iliac vessel. This is a right way, which is shown in green, is a right way of looking at the uterine artery PI. So you have to wait till you get a nice waveform of more than 60 centimeters. You see that systolic velocity is 100 more than 60 centimeters per second. What about the notching? Is it important? We know that notching is a 22% increase risk of PE. It is seen in 50% of women at 12 weeks of gestation. There's a 9-fold increased risk of small for gestational age, but it has got a lower specificity for preeclampsia. We are more concerned about the uterine artery PI. And of course, when you find a notching, you can mention it, but there's no risk assessment based on the notching. So mean artery uterine artery PI should be the Doppler index of assessment in the first trimester. So there's no doubt on that. So combined screening. So once you've done a history, the patient comes, you've done a systolic mean artery recording, the patient has come down, you've done a uterine artery PI in this patient. So what else should you do? You have clarity. We have a combined screening for preeclampsia also, which includes the maternal factors, history, demographics, cardiovascular, metabolic profile, and the placental markers like PAPA and PLGF. So in countries in low resources where PLGF is extremely expensive, you can do it based on your PAPA alone. And the mean arterial pressure followed by the uterine artery Doppler. Doppler cutoff alone should not be used as a standalone screening modality. Is very important. You have to combine with other factors to assess a risk assessment. So these are the few examples which I would like to show. Where diabetes, hypertension, SLE, this patient was absolute low risk pregnancy. You can see the mean arterial pressure at 73.3 centile is just on the 5th centile, so it's absolutely normal. mean arterial pressure. Next, we do the
One second.
beta
There's
HCG,
a lot
PAPA,
of
PLGF, and
background
AFP.
noise.
We find that the PLGF also is normal, 1.5 ml, which is absolutely
Dr.
normal.
Malti.
Some background noise.
Yeah.
Excuse me, madam, just 1 minute.
Just
There's a
hold
lot of
Malti for a
background
while.
noise.
They will. I think
Can I
we have to mute everybody. Let's mute everybody.
Can I
Can
request
mute
the
everyone.
technical people to mute
Yeah.
everybody, please, except the
So next,
speaker?
coming to the urinary PI, which is entered in the FMF software, you find that it is 1.36 and the centile is around 30 or 48 centimeters, which is absolutely normal. So when you do a risk assessment for this patient, you find that the preeclampsia risk before 34 weeks is 1:8171.
Dr. Malti, you have to unmute yourself.
Malti madam, please unmute yourself. Madam, can you unmute yourself, please? Malati ma'am?
Yeah, I'm unmuted.
Yeah, thank you.
Hear me now? So the previous was absolutely low risk pregnancy, did not require intervention. The patient is delivered and did not develop preeclampsia. So the next one is another one example which I would like to show you is you do a complete. This patient had history of chronic hypertension. That was the only risk factor which was picked up. She was SLE negative, APLA negative. Previous preeclampsia was negative, and we did a urinary PI which showed a normal mom's centile was a 30th or 40th centile. She only had one risk factor, like once again within normal limits, around the 60th centile. And risk assessment just based on the, and you can see the PAPA which is low, 0.7 moms, beta HCG is 1.2, and as can you see on the screen, the preeclampsia risk before 34 weeks is 1:122, and before 37 weeks is 1:34. This patient was started on aspirin, 150 milligram. Until now, the antenatal ongoing protocol is fine. She has not developed preeclampsia and the PAPA, which is low. So I just wanted to show an example saying that everything has to be taken into consideration based on the risk factors. And another third example is that this patient absolutely low risk pregnancy, no history of hypertension, diabetes, PAPA, moms, beta HCG absolutely normal. Can you see the urinary pulsatility index showing a mean of 2.74 more than the 95th centile? So this urinary alone is high. And as you can see, the patient has once again showed risk of preeclampsia 430 and 1 to 350. This patient had a MAP also, which was normal. So why I wanted to show you these examples was based on every factor, the maternal factors, MAP, urinary PI, and the PAPA, and PLGF, if the patient is affordable, should be done to assess the risk of preeclampsia. If she tests positive, next, what should we do? So as you know, the risk of preeclampsia is increased with the high MAPs, increased levels of FLIT, lower concentration of PAPA and PLGF, and urinary place. You just have to do the risk assessment at the end of the day and start the patient on management of aspirins. So it's a better predictor of early PI rather than late PI. So we're only concerned with the early PI because late PI is easy to manage. You just have to deliver. Early PI is one which requires close fetal and maternal surveillance. So maternal factors alone, as you can see, predicts only 50% of women with preeclampsia. Whereas when you add PLGF, it goes up to 60%. When you do a combined screening, there is a mean arterial pressure, the urinary PI, and the factors. It goes up to almost 75% of cases at less than 37. So I hope you understand that it's important to look at every other risk factor and arrive at a risk assessment so that you can do some justice to the maternal health. So as per the study was done on 1,776 women at high risk for preeclampsia based on first come menstruating. And they had one group 150 milligram of aspirin, found that 100% detection of PE developing before 37 weeks dropped to 75. And it was a very good trial where they started aspirin and prevented early onset preeclampsia by almost 40 to 50%. Detection of PE developing at less than 37 weeks of 43%. So it's important that, and based on this trial, we have started using 150 milligram aspirin. Now coming, once we have finished the first trimester, patients who have not come to you for the first trimester screening, what do you do? Is there any role for urinary Doppler in the second trimester? The bilateral diastolic notching in urinary Doppler is associated with increased risk of preeclampsia. And urinary PI in the first has got better screening as a tool for screening in the second trimester is still questionable. So how do we do it? Doppler examination is slightly different. You have to get at the, you have to move the probe so that you apply color Doppler on either side of the cervix can be done transfer because you assess the cervix and also have to have a look at the uterine PI. And you have to place the Doppler gate at the crossing of the iliac vessels. We use the Doppler gate at the side of the paracervical region here in the second trimester. You have to place it 1 centimeter below the crossover of the uterine vessels over the iliac vessels. Why? Because it is that point which has got a high peak systolic velocity depicted in uterine artery PI. And take 3 similar consecutive forms, and the PI is done with the machine. It's not a correct way of doing it because the peak systolic velocity, as you can see, is only 35 to 40. I put this video because this is a wrong way interpretation of doing a uterine artery PI. It should be at least 60 centimeter per second, where the angle of incination is less than 30 degrees. So once again, the mean PI more than 95th centile is suggestive of elevated PI. It is 1.44. So because you don't have software which does the elevated index, 1.44 by transabdominal approach and 1.58 based on the transvaginal approach. So the mean uterine artery PA decreases by about 15% between 20 to 24 weeks. So beyond 24 weeks, you generally don't do a uterine artery PA. So PI readings are higher in the transvaginal compared to TAS, and because of the closer proximity and lesser angle of incination. So we are depicting the fact that as a pregnancy advances, the decreased diastolic flow. So we are taking that into consideration to predict the risk of preeclampsia and fetal growth restriction. So detection rate, what is the performance of uterine artery second trimester Doppler? Detection rate of almost 10% predicts 85% of cases of early onset. The risk of early PI appears to be increasing with increased uterine artery PI. And predictive performance, so both the screening modalities are better for early onset preeclampsia. So once again, prediction is better for severe and complicated cases. Mean PA more than 1.65 predicts 40% of cases of all preeclampsia, and prediction rate is 70% of PE with FGR. And you have to take that into consideration if possible. You cannot do a PAPE or a FLIT in that method. So combined screening may not be very effective in the second trimester uterine artery Doppler, not because you can neither do the PHF nor you can do the FLIT. FLIT is done in the third trimester of pregnancy. Low fetal fraction, there's an increase of preeclampsia, but still not validated for preeclampsia as we would do for aneuploidy screening. So still under validation. So what about third trimester? We started doing third trimester uterine artery Doppler, especially for women present with fetal growth restriction. It has been found that 95th centile is 1.17 at 30 to 34 weeks of gestation. You usually combine it if the biometry is less than the 10th centile. You find elevated uterine artery PA, you put it as a stage 1 fetal growth restriction. So that's the reason we use a third trimester Doppler. But there are no randomized trials on the impact of third trimester screening, maternal, fetal, and neonatal outcome. So implication and routine practice for screening for preeclampsia is not there because the patient has already entered the third trimester. You've diagnosed gestational hypertension. So this point of screening does not occur in the third trimester of pregnancy. So a reverse uterine artery flow, progression to preeclampsia IUD is high. In the third trimester, when you find a fetal growth restriction, you have to do a PLGF and FLIT ratio. If it is more than 84, it says that the patient's mother is likely to have an adverse outcome. If it is less than 30, studies have said that the patient is not likely to develop eclampsia or preeclampsia complications. So that still, again, in our country is a big factor because of the economical concerns. So combined screening, combination of in the third trimester, combination of maternal factors, once again, FLIT and PLGF are better predictors of preeclampsia. Now, with a lot of concept, I think in UK, they started doing FLIT ratio of FLIT and PLGF, which is a predictor of adverse outcome. In our country, still waiting. The addition of uterine artery in the third trimester did not add the prediction. Placental volume and vascularization index have been used as predictors. Normal placental volume is about 45 reproducibility. Lot of studies on maternal hemodynamics like failure of cardiovascular adaptation, subclinical pregnancy, cardiovascular dysfunction. There's an increased risk of PI. Hazard ratio for cardiovascular disease is 5.4. Mean arterial pressure is that where we're looking at the hemodynamic instability. So you have to do a mean arterial pressure recording when you do a complete assessment of preeclampsia. So once you've seen that the patient is tested high risk for preeclampsia, what do we do? So we're doing all this and it has found that it can decrease significantly the risk of early preeclampsia. It should be commenced in the first trimester of pregnancy, at least before 16 weeks, should be continued till about 36 weeks of gestation, from 11 to 14 weeks. The dose of 150 milligrams, 75 milligram, big no, it's 150. milligram as per the NICE, SYOG, and the SOG recommendations. So as per trial says that do not use as a aspirin at low doses because the resistance, in spite of giving 75 mg, the patient is not going to respond. So always it has been shown that in vitro data showing that optimal dose to improve trophoblastic function is equivalent to 150 mg. Bedtime, it should be used at bedtime because of the diurnal variation. And the greatest risk reduction observed in women with compliance. If the woman is compliant, likely to decrease the risk of preeclampsia. It has reduced the risk of preeclampsia before 37 weeks by 62%, which is a huge percentage, and reduce the risk of preeclampsia before 34 weeks by almost 82%. So if you have done a proper first trimester screening, start the patient aspirin, you have obviously reduced the risk of preeclampsia, which is a major cause of maternal morbidity and mortality in our country. So aspirin second trimester ineffective when started after 20 weeks. There's no point in starting after 20 weeks. It should be started before 16 weeks of gestation. Multiple pregnancy, risk of preeclampsia is high for dichorionic twin, 14% for MC twins, and 0.6% for singleton. So high uterine artery resistance in monochlinic twin, again, is associated with increased risk of preeclampsia. We have twin-specific reference ranges for uterine artery PI. Always combine it with the maternal factors, uterine artery PI, PSGF. Detection rate is about 95% of women will develop preeclampsia, and combined screening is very effective in predicting to the extent of 100 and 99% respectively. So to conclude, a combination, always use a combination of maternal factors, MAP, uterine artery Doppler, PSGF, PAPE at 11 to 13 weeks, which is a most efficient screening model for identification of men at risk of preeclampsia. Start the patient on low dose aspirin, which can decrease significantly the risk of development of early preeclampsia when commenced in the first trimester. There is no point in starting it in the second trimester. Doppler examination uterine artery at the second trimester can be performed either transabdominally or transvaginally. There's no role for vascularization, is still not recommended. And the combined screening maternal factors for singletons can be used for twins also with twin-specific ranges. Thank you very much for your patient hearing. Thank you.
Thank you very much, madam. That was a very lucid and a good presentation on how to detect early onset preeclampsia by Doppler. You have told that.
Madam, I cannot hear you.
Hello, am I audible? Am I audible? Yeah, ma'am, thank you for that.
Yes, ma'am. Yes.
Yeah.
Yes, ma'am, you're audible.
Thank you for the lucid talk on early detection of preeclampsia by uterine artery Doppler. You have told us that it is a very good tool for the first trimester prediction. The mean uterine artery pulsatility index of more than 95 percentile is a good predictor, but we have to take into account the maternal factors and the combined screening, and the detection rate will be better. And as a screening tool, it is very good in first trimester because screening is something which can prevent the cause. Whereas in second trimester, it is more of a predictive tool and is not good for screening because we cannot prevent preeclampsia once second trimester sets in. And first trimester, the prevention is by using 150 milligram of aspirin, started as soon as 11 weeks of gestation and continued. And in second trimester, it can only predict. And of course, we can at least do an early delivery and not miss the baby. And in third trimester, the addition of uterine artery did not increase the predictive value. And in multiple pregnancy also, it is a good tool and detection rate is as good as 95%. And with combined screening and maternal factors and the PLGF, it becomes almost close to 100%. Thank you so much, madam.
Thank
you, Malati, for the very nice presentation.
Thank you, ma'am. Thank you.
Moving on to the next session. Next session is the role of ultrasound in preterm labor, for which I would like to invite the chairpersons. Dr. A. Parimala. She is the Assistant Dean of Savita Medical College. She is also the Professor and Unit Chief in the Department of Obstetrics and Gynecology, Savita Medical College and Hospital. She graduated from Raja Mudaya Medical College, Annamalai University, and did her post-graduation from Ramachandra University. Ma'am has more than 17 years of experience. She is an undergraduate and postgraduate teacher, mentor, and guide. She has been an external internal examiner for UG and PG course and has published various papers in index journals. And I will also like to invite the next panelist of the, next chairperson for the session, Dr. Nidhi Sharma. Ma'am is a professor of obstetrics and gynecology at Savita University. She has done a diploma in IVF and reproductive medicine from UKSH Universitäts Klinikum Schleswig Holstein, Germany. Ma'am has done a PhD degree in obstetrics and gynecology from Savita University. Ma'am has 100 index national and international publications and has authored several chapters in textbooks. She has been an editor of 2 books published in London Innovations. I would like to request the chairpersons to take over the session.
Thank you, Dr. Badma. I'm happy to introduce Dr. Tony Tan, who has come to enlighten us with the monitoring how to monitor and predict the preterm labor. And Dr. Tony Tan obtained his MBBS in National University of Singapore in 1993 and his specialist qualification in OBGYN in 2000. He was further trained in the fetal medicine, including twin pregnancies at Queen Charlotte's Hospital, London, for a year till June 2003. He was a consultant of OBGYN in the Department of Maternal Fetal Medicine, KK Women's and Children's Hospital till October 2008, and then the consultant of OBGYN and clinical director of Maternal Fetal Medicine, Raffles Hospital from November 2006 to June 2019. He has set up his own clinic, Tony Tan Women's and Fetal Clinic at Mount Alvernia Hospital from 1st July of 2019. He has also been appointed as the medical director of Alvernia Obstetric Screening Center from the same date. He was the president of the Obstetric and Gynecological Society of Singapore in 2013 to 2014 tenure, and chairman of Maternal and Fetal Medicine Committee of the Asia Oceanic Federation of OBGYN in 2013 and to 2017. He is a fellow of the Royal College of Obstetricians and Gynecologists, UK, and Academy of Medicine, Singapore, and member of the Royal Australian and New Zealand College of Obstetricians and Gynecologists. Sir, we are eagerly waiting to listen to your talk. Please take over, sir, doctor.
Thank you. Okay. Can you see my screen?
Yes, sir. Seen, sir.
Okay.
Yes, sir.
Right.
We can see you.
So the talk is on ultrasound and prediction of preterm birth and prevention of preterm birth. If we talk about preterm birth, there are, of course, the iatrogenic preterm birth due to preterm preeclampsia, preterm IUGR, as well as the spontaneous preterm labor and preterm premature rupture of membranes. I'm not going to talk about the first two. I think the first speaker has already spoken on preterm preeclampsia. I'm going to concentrate on preterm labor. And the prediction of preterm birth mainly is with the use of second trimester cervical length screening via vagina scans. Now, so on the prediction of spontaneous preterm birth, you can look at history of previous spontaneous preterm birth. And if there's no history of previous spontaneous preterm birth, we can look at the cervical length, less than 25 millimeters. That's the commonest cutoff we use now. Of course, we can also look for marker of inflammation or infection, including asymptomatic bacteriuria, bacterial vaginosis, as well as some other higher tech markers. But today we're going to concentrate on history and cervical length measurement. We know that as long as there's a history of a previous spontaneous preterm birth, then the chance of spontaneous delivery increases. Where there are no history, or where the no delivery at or beyond 16 weeks, or if all deliveries had been more than 37 weeks, the chance of spontaneous delivery below 34 weeks is very low, 0.5 to 1%. But as long as there had been 1 or 2 events, even if there was a pregnancy that went beyond 37 weeks, the chance of a recurrent spontaneous birth is actually very high. Of course, when we say spontaneous preterm birth, we do not include, let's say, a cesarean section done at 32 weeks for preeclampsia. That is not included in this history. If we look at cervical length at 18 to 24 weeks, you do find that as the cervical length increases, the risk of premature birth below 28 weeks, at 28 to 30 weeks, 31 to 33 weeks decreases. As the cervical length reduces, the risk increases. The Fetal Medicine Foundation has described a technique of measurement of the cervical length by vagina scan. At 20 to 24 weeks, the bladder has to be emptied and the patient is on dorsal lithotomy position. The vagina probe is introduced in the vagina and directed into the anterior fornix. You go in till you feel the cervix moving, and then you move back until you almost cannot see the cervix, and then that would be the perfect position. So no undue pressure on the cervix. We look for the sagittal view of the cervix. Look out for the endocervical mucosa. The cervix has to be enlarged till it occupies almost the whole of the image. And we use the calipers to measure the linear distance between the triangular area of the echo density at the external os and the V-shaped notch at the internal os. This is a linear distance, not a curved distance. We should do this over a period of 2 to 5 minutes, take at least 3 measurements, and then take the shortest. In about 1% of cases, the cervical length may change due to uterine contractions, and in such cases, the shortest measurement should be recorded. This is the cervical length of vagina scan. You can see the cervical canal from here all the way to here. So that's the internal os, that's the external os. And this is a video I got from ESWOC. You can see you press on it, it comes in like this, and you freeze, and then you measure from here to here. Now, you got to differentiate the endocervical mucosa from the stroma. You can see the echogenicity here and here slightly different. And that's the endocervical mucosa, and the cervical length is measured from here to here. Again, another picture, internal os is here, external os is here, bladder is empty, the canal is actually a curve, a length, but the distance is measured as a linear, as a straight line. And therefore, whatever we measure is really slightly less than the real thing. This is a funneling of the cervix, and then the cervical length here is short. Now, cervical funneling is present in about 4% of cases. It is increased, the prevalence increases when the length is short. If it is less than 15 mm, almost all of the cervixes will have funneling. And if it's more than 30 millimeters, almost none will have funneling. Now, those with funneling has increased risk of spontaneous preterm labor compared to those without. However, if you correct them for the cervical length, then funneling does not provide a significant additional contribution. So forget about funneling, just measure the cervical length. Why don't we measure transabdominal cervical length? Well, the problems are that to look at the cervix abdominally, you need a good ultrasound machine. You need a bladder to be full, because with the full bladder, you can see better. But the problem with filling up the bladder is that the bladder falsely increases the cervical length, and therefore the mean cervical length increases from 32 millimeters to 46 millimeters. And therefore this will falsely increase your cervical length, and therefore it's not so good. And of course, if the cervix is long, it's easier to visualize, and if the cervix is short, it's harder to visualize. And really, we are doing this scan to look for a short cervix. So we can't afford not to be able to see the cervix. and then pass it over. Now, that was the easy part, the prediction based on history and cervical length. The prevention of preterm labor is going to be the difficult part of the talk and more exciting as well. Let's summarize, and I've modified this table from Roman in this publication, COG in 2016. Let's talk about singletons. I've got another talk for twins. It's a little bit different, but let's be simple and let's just concentrate on singletons. We can divide singletons into 3 groups. Those where there are no prior history of spontaneous preterm births, about 90% of them are here. About 9% may have a prior spontaneous preterm birth, and less than 1% will have more than one episode of cervical incompetence where you had a spontaneous, painless loss of the pregnancy in the mid-trimester, or a history of previous sucklage for painless dilatation of the cervix, or if there's a history of 3 or more prior spontaneous preterm births. Let's concentrate on this. Now, the treatment, cervical sucklage can be done with McDonald's sucklage, which is easier to do, or the Shiroka sucklage. Now, there is an ongoing effort at meta-analysis by some authors to check if one method is better than the other. At the moment, no data to prove which one is better. Most of us will just use the method that we are trained in. A lot of us use McDonald's because it's easier to do. Now, consensus statements from ACOG, SMFM, RCOG is that if you have a history of more than or equal to 1 second trimester pregnancy loss related to painless cervical dilatation and no history of labor or abruption, or if there is a previous second trimester sucklage for painless cervical dilatation, or if on examination you see painless cervical dilatation before 24 weeks, these are accepted indications for the treatment for using sucklage to reduce preterm birth. If we look at a Cochrane study published in 2017, actually, if you use history, if you look at 1, 2, 3, 4 studies, if you look at the 4 studies and you total them up, doing sucklage based on a history, whether it's for less than 37 weeks or less than 34 weeks, actually, there seems to be a slight advantage, but really it's not statistically significant. And it's really pushed to the left because of this study by Izichi in 2004. But despite that, a lot of us will still do a sucklage for history. What about emergency sucklage for painless cervical dilatation? Now, this is a very recent meta-analysis by Chatzakis in 2020, where there are 4 studies. If you look at the 4 studies, if you do not do anything, 55 out of 65 actually go on to deliver prematurely, whereas if you do a sucklage, only 34 out of 111. And this is clearly useful to do a sucklage for painless cervical dilatation less than 24 weeks. So the primary outcome for this is a preterm birth before 32 weeks. So if you have this history, if you are the super high risk, consider the cervical sucklage at 12 to 14 weeks. And if this patient had a failed transvaginal cervical sucklage previously, you may want to consider transabdominal sucklage. Now that's a harder surgery to do, and I think not many people in the world have a lot of experience doing this. Now next, let's go to a singleton with a prior spontaneous preterm birth. Let's talk about the story of intramuscular 17-alpha hydroxyprogesterone caproate. In the mice study published in the New England Journal in 2003, they studied 463 women with a past history of spontaneous preterm delivery, and they showed that giving this IM injection 250 milligrams weekly from 16 weeks to 36 weeks reduces the risk of delivery by about 30%, below 35 weeks by about 30%, below 32 weeks by about 40%. So FDA at that time accelerated the approval for Martina, the brand name for this medication, for the indication of prevention of preterm birth when there is past history of spontaneous preterm birth. But they required them to do post-approval marketing study and reporting. And of course, the company went on to try and make a lot of money from it. The initial cost was $1,440 per injection, or $30,000 US for 18 to 20 injections per pregnancy. And it was cut to $690 per injection, or $15,000 per pregnancy. And finally, there were generics that were available at $15 per injection. So for a while, a lot of us were giving IM injection weekly from 16 to 20 weeks. And then as we said, part of the post-approval marketing and monitoring, they had to do this study, and they recently published this in 2019 called the Prolonged Study. They did 93 clinical centers, and they studied 1,700 women, and they gave it 16 to 20 weeks to 36 weeks. And in this study, they had lower rates of preterm birth compared to the initial mice study. And in this study, they showed that whether you gave 17-alpha hydroxyprogesterone caproate or you gave placebo, there was no difference in preterm birth rates. Consensus statements by ACOG as well as SMFM continue to support the use of this IM injection, provided the group of patients was similar to the 2003 paper. Because in the 2003 paper, there were more blacks, more smokers, whereas in a prolonged study, more whites, less smokers, and in the NIH-CHD study, more of them had preterm birth history, whereas this side had less. Well, in the UK and Australia, it was an easier thing because they have never had it. They do not have this available, and therefore there was no guideline on its use. But because of the prolonged study, I think this is no longer useful for us anyway, because we do not have that many blacks in our population in Asia. Now, the vaginal progesterone has also been used for past history of spontaneous preterm birth. So there was this study in 2017 where they look at it's a meta-analysis of 3 smaller studies. In 2012, they studied 90 milligrams of gel daily versus 200 milligrams of micronized progesterone as a pessary, or 100 milligrams. And these are all small studies. But in these small studies, there was some evidence to say that it reduces the spontaneous preterm birth below 34 weeks and below 32 weeks. And you could see here that there was some advantage giving progesterone, but mainly from the gel rather than from the micronized pessaries. Because of that, and we do not have much things to use, you may want to consider using progesterone gel, 90 milligrams once a night, or micronized progesterone, 100 to 200 milligrams once a night. Now, if you are giving progesterone, a suggestion is also to do fortnightly transvaginal cervical length from 16 to 24 weeks. And if they are in the borderline group of 25 to 29 millimeters, consider weekly cervical length measurements. Because once you start doing the cervical length measurements, you might then have 3 groups of patients, one where the cervical length is normal, one where it's very short, less than 15 millimeters, and one where it is intermediate between 16 to 24 millimeters. There's some studies as well here where they show that vaginal progesterone for past history of spontaneous preterm birth and a short cervix, they showed that vaginal progesterone is as effective as cervical cerclage to prevent preterm birth in women. And you can see here less than 35 weeks reduction of risk ratio of 0.68 risk ratio of 0.7 with subclutch. However, you can see that subclutch works better for the secondary outcomes, and for vaginal progesterone, it's only good for the outcome of preterm birth less than 32 weeks. And if you look at cervical length less than 60 millimeters, you see that subclutch does better than progesterone. Therefore, a suggestion here is that if the cervical length is very short, offer subclutch. If it is more than 25 millimeters, continue management as per normal. And if it's intermediate, think about using vaginal progesterone, which is less invasive, or offer subclutch, whichever one you think works. A lot of us just start with vaginal progesterone, and if the cervix continue to shorten despite progesterone, then we do the subclutch. Now let's go to the majority of patients. Majority of them will not have any prior history of spontaneous preterm birth. So in this group, we recommend that the cervical length is measured at about 18 to 24 weeks. And if the cervix is short, there are 3 possible management options: vaginal progesterone, cervical subclutch, or subclutch pessary. If the cervical length is more than 25 millimeters, less than 15 millimeters, or 16 to 24 millimeters, let's talk about vaginal progesterone for short cervix. The original study was by Fonseca, in part of the Nicolaides group, and they studied cervical length less than 15 millimeters. They gave vaginal micronized progesterone 200 milligrams from 24 weeks to 33 weeks, and it reduces risk of preterm birth by less than 34 weeks by about a factor of 44%. Hassan, 10 to 20 millimeters vaginal progesterone gel reduces the risk of premature birth by a factor of 45% and 50% here. Now, then the Optimum trial came out and threw a spanner to this whole idea. And basically in the Optimum trial, they studied 1,228 women, and they said no difference in the primary obstetric outcome measure or neonatal outcome. But mind you, look at this paper. They actually studied 3 different types of patients. One with a previous history, one with a short cervix, and one where there is a positive fetal fibronectin test with one other clinical risk factor. And therefore, it's very different from the other 2 studies where they concentrated just on cervical length. And post-Optimum study, Romero did a meta-analysis where he just isolated singletons with a short cervix, and he found that actually when you include all of them together, vaginal progesterone reduces the risk of preterm birth by a factor of 40% if you only concentrate on singletons with a short cervix. Cervical subclutch, we have talked about this. And again, if you do cervical subclutch for ultrasound indications, you can find that, hey, not much. There's seem to be some benefits, but it is not statistically significant. However, if you concentrate just on the cervix less than 10 millimeters, where there's no history of spontaneous preterm birth, this of course is a small study, retrospective study, very newly published, and subclutch has been shown in very short cervix to lengthen the interval to delivery, and more so if the patient had already been treated with vaginal progesterone and they had less late preterm births as well. And this makes sense as well because there was another meta-analysis where they looked at cervical subclutch in twin pregnancies. And if most of you who are keeping in touch with the literature, you would know that cervical subclutch has always been contraindicated in twin pregnancies. But in this systematic review, they showed that in twin pregnancies where the cervix is very short, less than 15 millimeters, or if the cervix is dilated, studies have, this meta-analysis have shown that it is useful. So subclutch seems to work well for singleton and twin pregnancies where the cervix is very short. and maybe between 10 to 15 millimeters. Let's talk about cerclage pessary. This is the Arabin pessary. I think it's German. And it is passed down from the Arabin family. It's a non-invasive. You put it in, fit the cervix like a cerclage, except that you don't have to do surgery. So initially, a Spanish randomized controlled trial showed that it works very well. Subsequently, there was a Hong Kong study and a European study led by Nicolaides showing that it doesn't work. And if you look at this meta-analysis, it's slightly better pushed by the Spanish study, but really not statistically significant at all. So in summary, if it is more than 25 millimeters, continue management. Less than 15 millimeters, do a cerclage. And if you are 16 to 24 millimeters, do vagina progesterone, give about 100 to 200 milligrams once a night. And if you are giving them vagina progesterone, weekly cervical length until 24 weeks. And if the cervix shortened to less than 15 mm despite progesterone, consider cervical cerclage. So in summary, past history of premature birth, less than 37 weeks, do vaginal progesterone, micronized progesterone pessaries 200 milligrams once a night, or do a cervical cerclage if there's a cervical incompetence or previous second trimester loss, and if the cervix shortens despite progesterone. The cervix is short, less than 25 millimeters, do a vaginal progesterone, and if the cervix is less than 15 millimeters, consider cerclage. If you have a short cervix and previous preterm birth, give vaginal progesterone or cervical cerclage. There are now some studies to try and look if the combination of vaginal progesterone and cervical cerclage is working, it's going to work better than one or the other. So that's my last slide. Thank you for your attention.
Thank you, sir. It was a very elaborate and an enlightening talk. For your precious time. You discussed the causes of preterm initially, with the iatrogenic spontaneous causes and preeclampsia being one of them. You taught us how to identify the cervical length with the second trimester screening, and the technique for the measurement of cervical length was very good. And you told us that how to go from the internal area of the internal os at the triangular to the external os, and the slides were very beautiful. And sir, you have also given us beautiful images, and you told us about the different types of prediction of preterm based on history and based on the previous history of spontaneous miscarriages or spontaneous preterms. You also told us that the transabdominal ultrasound can falsely increase the cervical length from 32.5 to 46 mm, and it requires a full bladder. So transvaginal ultrasound is a better method than a transabdominal method. And a transabdominal is also difficult to visualize short cervix. You told us that about the singleton management in singleton pregnancies. So you have discussed about the cerclage methods and the medical management. And you also told us about the Cochrane review. And you told us history indicated cerclage had benefit in the Cochrane review, and emergency cerclage for painless cervical dilatation was clearly useful in all the studies. And sir, you have also told us that if there is a history of previous failed cerclage, then transabdominal cerclage will be better. And you mentioned about your study published in the New England Journal of Medicine about the 17-alpha hydroxyprogesterone caproate 250 milligram IM injection. Actually, it is very nice to hear from sir yourself, your own study. And you told us how it was useful in less than 35 and 32 weeks. And you also told us about the cost benefits and subsidies which were offered after your study. So that was really enlightening, sir. Then you told us about the gel being more useful than micronized pessary. And you told us about the management, like 16 to 24 weeks. It will be better to do a fortnightly cervical length. And in 16 to 24 weeks of cervical length, a vaginal 16 to 24 cervical length, vaginal progesterone will work. And in the monitoring, if anytime the cervical length goes less than 16, we need to do a circular. So that was a very beautiful guideline which we have learned today. And you also told us about the optimum study, which was a true spanner. And you told us about the controversies regarding the Arabian pessary. And you told us that cerclage extends. So, sir, it was a very enlightening talk. And sir, thank you so much. Sir, one small question I have for you, sir. Is it okay? Can I ask? Can I ask a small question, sir?
Yes, please. Yeah.
Sir, you told about this hydroxyprogesterone being used 250 milligrams. And that was a weekly injection. And then you told us about the gel dosage. You have told 90 milligrams, is it?
The gel, yes. Yeah. Gel is 90 milligrams. Yeah.
Gel is 90 milligram and it is once every night.
Yes.
And the injection is like 250 and it is once a week.
That's the injection. Yes.
That's a once a week. Okay, sir.
But the follow-up study. Sorry, it wasn't my study. It was a mice. The first author, his name is called Mice, MEIS. So it wasn't my study. What I meant was the author was mice, and it did. Initially, the study showed it worked, but a bigger study after that showed that it didn't work. So actually, I've stopped using it now, the IM injection, because yeah. So when it showed that it worked, I started using, and once it showed that it doesn't work, I've stopped. Yeah.
Thank you so much, sir, for your precious time. Thank you so much.
Thank you, Dr. Tony, for your valuable insight on the topic. I'm sure this will go a long way in understanding the concept. Moving forward to our next session, role of ultrasound in placenta accreta syndrome. This session will be chaired by Dr. Shivasundari and Dr. Rajalakshmi. Dr. Shivasundari is the professor of obstetrics and gynecology, Savita Medical College. She has obtained 10 gold medals, 13 awards for MBBS exam and university exams, presented by Tamil Nadu Dr. MGR Medical University and Indian Medical Association. She was the best outgoing student MBBS in the year 1999, and she had received the IMA gold medal for OG in MBBS. She has received the Dr. Vijaya Patil Prize Medal 2012 awarded by RCOG London, UK. She has received the Mrs. Chandravati Devi Jagannath Prize for Best Paper in Oncology in AICOG 2015. She has received the Best Poster Award in Pressa Pressure AICOG 2015 and Best Poster 5 is Not Enough Oxy 2014. She is part of the organizing committee ATNRCOG RCOG Conference 2016 Mahabalipuram, and she was part of the organizing committee Refresh 2017-2016, OG Quest 2014 till 2017. She has been invited as a speaker in ATNRCOG Refresh, OG Quest, Oxy, Yuva Foxy. She has lifetime membership of RCOG and undergraduate, postgraduate at MRCOG examiner. About our next chairperson, Dr. Rajalakshmi. She is the professor of Savita Medical College, undergraduate examiner, guide and mentor for UG and PG. Now I request the chairpersons to kindly take over the session.
Thank you, Monica. Dr. Sudarshan Suresh, he has done his MBBS from PSG Institute of Medical Sciences and Research, Coimbatore. He has done his DNB in Ops and Gynec from Southern Railway Headquarters Hospital, Chennai. He has done his fellowship in fetal medicine 2012 in Mediscan Systems. And he is a consultant in fetal medicine in Mediscan System. He has extensive experience in ultrasound and fetal medicine training, both in basic and advanced. He has extensive experience in fetal diagnostic therapeutic invasive procedures, amniocentesis, chorionic villus sampling, fetal reduction, fetal blood sampling, intrauterine blood transfusion, radio frequency ablation, fetoscopic laser. He has experience in high-risk obstetric ultrasound, evaluation of complex fetal anomalies and multiple pregnancies. He has organized protocols for specialist units in fetal medicine and set up protocols in place for first trimester unit, multiple pregnancy clinic invasive procedures unit, and been running it since 2015 in Mediscan system. He is the joint organizing secretary in CUSP and biannual national conference in ultrasound and fetal medicine. He has guided many students in paper publication. Over to you, sir.
Can you see my screen?
Yes, sir. We are able to see your screen.
Just give me a second.
Sure. Sir? Sir, are you able to hear us? Sir?
Yeah.
Yeah.
Sorry, my system got shut down. That's why there is a problem there. Yeah. Can you see my screen and hear me now?
Yes, yes.
Yeah.
Yes.
Okay. So over the next 20 minutes, I'll be discussing about this topic on placenta accreta spectrum disorder and the role that ultrasound plays in the evaluation and management of the same. So placenta accreta spectrum disorders is actually not a binary condition, like it's a normal versus an abnormal. It is actually a heterogeneous group of abnormalities, and it is characterized by an abnormal adhesion or invasion of the trophoblastic tissue into the myometrium. It can extend, as I said, from completely normal, where at the time of delivery there is a spontaneous placental separation, where you may have a part of the placenta alone that is adhered, what we call as a focal accreta, where a piecemeal manual removal may be required, but the rest of the placenta gets separated, to the other end of the spectrum, where the placenta is completely adherent to the myometrium or invading into the nearby structures or even into the parametrium, which is varying grades of placenta accreta, increta, or percreta. Our concerns is that these conditions, if adequately diagnosed prenatally, helps us to plan and prepare for a difficult surgical management rather than met with a surprise at the operating table. So this is a normal placenta that we see. This is a picture and an autopsy picture. And here the fetal surface and the placental surface. And what we try to do on ultrasound is try to see how much of this we can replicate on our evaluation. So what are we trying to learn in today's session is we are trying to learn how to define a low-lying placenta, how to image and classify the low-lying placenta and see the different kinds of placenta previa, and how ultrasound helps determine the placental adherence, and to see how we can put this to clinical practice by an optimum reporting method. Let's begin with assessment of the placenta in the first trimester. In the first trimester, the placenta, more often than not, encompasses the uterine cavity. And if you look at the first trimester evaluation of the uterus and the placenta with the cervix on the transvaginal scan, the lower edge will always seem to be closer to the internal os. And hence, as a rule of thumb, we should avoid reporting on a low-lying placenta in the first trimester. When we move over to the second trimester scan, in the second trimester scan, we try to evaluate the placenta by 3 locations. That is the fetal surface and the maternal surface. The fetal surface is the hyperechogenic chorionic plate, and you have the placental substance. The maternal surface, the maternal point is the myometrium, and in between the myometrium and the placenta, you have this hypoechoic space, and this hypoechoic space is called as a retroplacental free zone, and that is what we are focused on when we image the placenta in the second trimester. So once you start imaging the placenta or imaging the baby, we start with imaging of the placenta, and we should do something called as a placental localization. And that is done by 2 methods. One, keeping the probe in the longitudinal direction, and then keeping the probe in a transverse plane on the maternal abdomen. In the longitudinal direction, you keep the probe in the maternal abdomen and slide it along the anterior uterine wall and move the probe from the left to the right side of the maternal abdomen. And similarly, turn the probe transverse to the left and the right paramedian surface to see if there is any placenta in the lateral wall. If you can note this video clipping, we can see the placenta that is anterior being traced from the upper edge to the lower edge. This is the lower edge, bladder, head of the baby, and that is the lower edge of the placenta. And we slide along the uterus to trace the placental substance and also look at the retroplacental free zone all along till we reach the upper edge of the placenta. In a similar vein, if we want to see a placenta that is on the lateral wall, as I've said here, we have to rotate the probe to the transverse plane. Herein, if I stop this image here, you can see a placenta in the anterior wall and the posterior wall, but a rotation of the probe to the transverse plane tells us that it is connecting along the lateral wall also. So once the pregnancy reaches the third trimester, our key point in placenta localization is to see if the lower edge of the placenta is above the presenting part or below the presenting part. Like this, if I see the head of the baby hitched against the cervix, it is a sine qua non that the placenta is not low-lying. So what is the checklist that we need to have in mind when we have to look or trace for an abnormally adherent placenta? We need to have a good history. We need to learn how to localize the placenta, which I've said already. We need to be able to assess the morphology of the placenta and assess the lower limit of the placenta and see how to report the same. And when we want to report a placenta as low-lying, we have to do a transvaginal scan. It is not done by a transabdominal method. In the transvaginal scan, we look at the inner edge of the internal os, and when you assess this, we have to make sure that there is no myometrial contraction here. And in this picture that is seen here, that's the internal os, that's the external os, that's the lower edge of the placenta, and this is seen to be just abutting the internal os. So placenta is termed as low-lying when the lower edge abuts within 2 centimeters of the internal os. And any pregnancy where in the mid-trimester scan, we see the lower edge of the placenta within 2 centimeters of the internal os, we need to follow that pregnancy up in the third trimester, and we shall see how we can do that. There is a concept that the placenta can migrate. What is this concept? When the uterus enlarges in size, there is a differential enlargement where the uterine size grows much larger than the placenta, and hence it is not essentially a placenta that is migrating. It is in turn a uterus that is growing large. So this is an example of a pregnancy where the placenta in the second trimester was around 1.5 centimeters from the internal os. And in the third trimester scan, you can see the head of the baby hitched here and the placental edge is well away from the internal os. So whenever we see a low-lying placenta in the second trimester, evaluate the placenta again once in the third trimester at around 32 to 34 weeks in pregnancies which have no significant prior history. When we look at abnormal placentation, we saw how the placental edge just abutted the internal os. In this particular picture, this is the internal os of the cervix. You can see that the placenta seems to be covering the internal os in its complete. And whenever you have a placenta that is covering the internal os completely, like what we call as a central placenta previa, and is in these scenarios where we are worried whether the placenta is adherent to the myometrium or not. And in that regard, ultrasound plays a very, very important role. And how do we look for signs of placental adherence on ultrasound? We have certain specific signs on ultrasound, and we shall look at them one by one and see how much predictive ability they have as independent parameters and in toto. Placental lacunae. These are large, irregular sonolucent areas. By sonolucent, I mean black in simple terms, and they are seen within the substance of the placenta, and this gives the placenta a moth-eaten appearance. These placental lacunae are very similar to the placental lakes which can be seen in a normal placenta, and hence we attach importance to them only in pregnancies where the placenta is low-lying and it's covering the internal os. In a normal placenta that is seen well away from the internal os, when you see black spaces inside the placental substance, they are called placental lakes. And in placenta which is completely covering the os, when you have these large moth-eaten spaces, and when you switch on the color Doppler, if you see significant vascularity in it, these are called placental lacunae, and these are seen in around 75% of pregnancies which have a morbidly adherent placenta. So hence, you need to look for these placental lacuna spaces. We already saw that we need to look at a space behind the placenta. So whenever we evaluate the placenta, even in a routine scan, it's a good practice to train the eye to look for the black space behind the placental substance. And this is called as a retroplacental clear zone. If you look at the second point we need to see, this is a normal retroplacental clear zone that is seen. This is a placenta that is covering the internal os. You can see these moth-eaten spaces or placental lacuna spaces. Also, what you can address here, there is no retroplacental clear zone between the myometrium and the posterior border of the placenta. And a heterogeneous or an absent retroplacental space is seen in over 90% of the cases of adherent placenta, and hence we need to go back and look at the retroplacental space anytime the placenta covers the internal os. The key point here is this has got a very, very high negative predictive value, which means when you do not see these spaces, then it means it's got a good value. Give me a second, ma'am. I think there is a problem in my system. I need to restart this for a second.
Sure, sir.
Yeah, so I shall continue where I left. So normally we see a white line that is right between the posterior margin of the placenta and the bladder. And this white line represents the intact bladder to the uterine serosa interface. And when there is a thinning or interruption of the bladder line, this is seen in around 70% of the adherent placenta. And what is this bladder line interface interruption? This is basically an artifact that is caused due to a tangled mass of blood vessels that is seen at this picture, as you can see in this slide. And the fourth point we need to assess is the presence of uterine hypervascularity. Uterine hypervascularity is basically a dilatation of the uterine artery, the spiral arterioles, the artery, and the arcuate arteries. This is a picture of the placenta accreta picked up from the net, and this is how these enlarged blood vessels appear. But on the ultrasound, when you take a two-dimensional slice through this curved surface with these tangled mass of blood vessels, you see a picture right like this. So whenever you see an increased vascularity between the bladder to the myometrial interface, and this it actually doesn't mean that the placenta or these blood vessels are invading the bladder. It explains about these dilated vessels that are seen inside the uterine serosa that you can note here. In addition, you can also see these dilated tortuous vessels within the placental lacunar spaces, and these are representing the high velocity flow in the arcuate vessels inside the placenta and the uterine wall. So when you see an increased vascularity at the bladder to the myometrial interface, it is seen only in morbidly adherent placenta, and this has got a very, very high specificity. This is an example of an adherent placenta where you have this moth-eaten appearance of the placenta, what we call a very dirty appearing placenta. And when we switch on the color Doppler, you can see significant vascularity within the lacunar spaces, and there is an absence of the white line between the bladder and the uterine serosa. And this interruption of this white line is basically because of the artifacts caused by these blood vessels. This is a B mode and a color Doppler ultrasound showing the same. The last stage of the placental abnormality is the placenta percreta, which is very less commonly seen. And this is a scenario where there is a breakthrough of the myometrium, wherein there is a complete absence of the myometrium where the placenta extends into the serosa or beyond. This is a rare scenario where you actually see a bulge of the myometrium within the bladder wall, or apparent protrusion of the placenta inside the bladder wall. The placenta does not go inside the bladder wall, but it has invaded the wall of the bladder, where surgical handling of the same has to be very, very difficult. So with these 4 points that we have in mind, what are the technical issues that we need to take home? Number one, when we do an ultrasound assessment of the placenta, we need to use a combination of a trans-abdominal scan and a transvaginal scan. Transvaginal scan for diagnosis of the placenta previa or low-lying placenta is extremely safe. And if there is a persistent low-lying placenta or a placenta previa at 32 weeks, you again need to do a transvaginal scan in late trimester at 36 weeks also. When you come to, I'm so sorry, ma'am. in my system, it's shutting down. I'm so sorry for the difficulty.
No issues, sir.
Yeah, as I was saying, so the other key point in the technical issue that we need to see is cervical length measurement. Cervical length measurement helps to facilitate management decisions in asymptomatic women with placenta previa, because when you see a pregnancy with placenta previa and adherence, and if there is a short cervical length on transvaginal scan before 34 weeks, then we need to have that in mind, because this can increase the risk of a preterm emergency delivery, and this has a significant bearing on the mode of obstetric care. The other technical point we need to have in mind is whenever we want to look for assessment of placental adherence, fill up the bladder. Because only when you fill up the bladder, you will be able to see this outline between the uterine serosa and the bladder wall. And without a full bladder, you can see that this interface between the bladder and the uterine serosa can never be seen. The other thing is probe pressure. When you give excessive amount of probe pressure, the retroplacental black zone can be falsely closed, and you might think that there is a placental adherence. Second, when you use color flow mapping, you have to know the technical aspects of color Doppler. You need to adjust the gain and the PRF appropriately, or else you would have a false appearance of a placental adherence. So two things which can make you think of a placenta accreta spectrum when it is actually not there is an excessive probe pressure or inappropriate adjustment of the color Doppler method. So with these background factors, how do we screen for an abnormal placenta? When there is a history prior more than 2 LSCS, uterine surgeries, multiple DNCs or surgical evacuations, classify as high risk. And in these pregnancies, when an ultrasound at 20 weeks shows a placenta is within 2 centimeters of the internal os, then we need to assess for past spectrum disorders. And in this method, we need to use the above techniques which I said. If you look at the first trimester, I will put up this case. This was a second gravida, previous 1 LSCS. And at 9 weeks, we had a gestational sac which was implanted at the lower end of the uterine cavity. It was actually referred as a scar pregnancy. It wasn't. The gestational sac is very much at the lower end of the uterine cavity. And this pregnancy at 24-25 weeks, it belonged to a placenta accreta spectrum grade 2. I shall speak about that. And it ended up having a significant adverse outcome with a cesarean hysterectomy, with the mother and the baby having a lot of problems.
Madam, you are not at all audible. Dr. Girija? You are not audible, Dr. Girija.
Girija ma'am, you have to unmute, please.
You are not audible, Dr. Girija.
Ma'am, Sudarshan sir is presenting, ma'am, and I think his system got stuck up. So he has to finish his presentation. Sir, are you able to hear us, sir?
I think I'll run this with without screen share. Because I
Okay,
think if
sir.
I put on a slideshow, it's shutting down the system.
Yeah, sure, sir.
So can you see this part of my screen this way?
Yes, sir. Yes, sir. We are able to see it.
Yeah. Yeah. So whenever you have a previous cesarean section with a low-lying sac in the uterine cavity at 10 weeks, there is a high possibility of a placenta accreta, which we need to look for. So how do we stage the placenta accreta spectrum disorders? Because that is how we report them. Class 1 is PAS 0, where there is a placenta previa. We have seen how to identify that, but there are no signs of invasion. We have seen the 4 signs of invasion already in the prior slides. This is an example of a PAS 0. There is a placenta covering the internal os, and there is no retroplacental space loss, and there are no intraplacental lacunar spaces. There is no abnormal vascularity, hence less chance of a complication. PAS 0. PAS 1 is when you have at least 2 of the 2 placental lacunar spaces, and you also have a loss of the retroplacental clear zone and bladder wall interruption. This is an example of the same. A placenta covering the internal os, and here you have multiple placenta lacunar spaces and loss of the retroplacental clear zone. So you have 2 features here, but there is no abnormal vascularity. So this is considered as PAS 1. Okay.
Hello. Hello. Hello.
Dr. Sudarshan?
Madam, I was disconnected for a while. I don't know why.
Yeah. Dr. Sudarshan, can we continue your lecture?
We can't hear anything. We couldn't hear anything for a while.
Hello?
I have changed my system. There was my system shut down. I've gone to a different system now.
Okay, okay.
Yeah, there shouldn't be any problem from now on.
Okay.
Yeah, I'm so sorry. Yeah. So you can see the slides now, ma'am?
No, doctor. No.
No, sir. No, sir. We are not able to see.
Yes. Yes, right now, ma'am?
Yeah,
yes, sir.
Yeah.
Hello.
So this is we were in PA stage 1. So PA stage 2 is one where you have a prior stage with significant uterine hypervascularity, and stage 3 is where you have a hypervascularity at the lower end of the uterine segment, which extends into the parametrium. So this is an example of a PA stage 2, very similar to the previous thing, except that we had significant hypervascularity as is noted in this video. And you can see this hypervascularity extends up to the bladder line that is noted here. So again, this pregnancy had an elective classical cesarean section with a subtotal hysterectomy, but because it was well planned and prepared, there was no significant adverse maternal outcome. So what does this staging actually signify for the obstetrician when you go for a delivery? Is that based on the stage, it translates to a fair extent to the FIGO staging of placental adherence at the time of delivery. So when ultrasound reports as PA stage 1, it's called placenta accreta or FIGO grade 3. If it is PA stage 2 or PA stage 3, it means there is a focal or a diffuse placenta percreta. So what is the role of MRI? The recent evidence based on 2 systematic meta-analysis actually gives a very similar sensitivity and specificity for both obstetric ultrasound and MRI, and they have comparable accuracy only, and hence the primary modality of diagnosis for an abnormal placenta is only an ultrasound. I will leave with the last couple of cases and how to report them based on what we have learned till now. This is case 1, a placenta that is completely covering the internal os, but what we have normal black space and no lacunar spaces. So the methodology of reporting on ultrasound is a placenta that is posterior and low lying, lower edge covering the internal os with no placental lacunar spaces and a normal retroplacental space. Final impression, a placenta previa with no evidence of adherence. So a very detailed reporting methodology helps the clinician significantly. This is another case, and how do we report this one in turn? So this is a placenta that is completely covering the internal os, lot of lacunar space is seen, significant vascularity noted, and the bladder line is interrupted and it is irregular. So the reporting would form this way. There is a placenta previa, multiple lacunar spaces, extensive neovascularity, thin myometrium, PA stage 2. So there is a probable invasion into the bladder wall, and this helps prepare the clinician for an appropriate mode of delivery planning. So this is the last case. This was a pregnancy at 22 weeks. Okay, this was a placenta that was covering the internal os fully, and these are lacunar spaces that were seen, and there is some vascularity seen. And this was reported there as a placenta previa. The patient came back for a growth scan, and the growth scan, the baby had an evolving abnormality. There was a significant bladder outlet obstruction, and there was a posterior urethral valve. There was anhydramnios at 29 weeks. So the entire focus turned to the baby, and the placenta, which was covering the os at the second trimester scan, skipped the eye. And because it's always a poor cousin when there is an anomaly in the baby. And the report was given as anhydramnios with a bladder outlet obstruction. Delivery was taken unplanned, and if for me to tell it was unplanned is an understatement, because when I got feedback from the clinical team, this pregnancy actually ended up having an emergency cesarean hysterectomy with a bladder and repair, because it was a tertiary institution, they were able to handle things without significant problem. And a very, very big lesson to learn is that always placenta first and fetus next, because this gives problems to the mother. So to conclude this talk, a combination of trans-abdominal and vaginal scan is mandatory to address the placental problem. A systematic way of reporting is essential. Whenever there is a prior history and a low implantation sac, keep a close watch for Akrita syndrome. An ultrasound staging of past disorders shows a good correlation, and hence this can be used to plan the delivery. And as I said in the last slide, placenta first, fetus next. Thank you very much for a patient listening. And I'm very sorry for the system shutdown which happened to block the talk 3 times.
Thank you, sir. We had so many obstacles also. Finally, we ended up having a gold medal in Olympics yesterday. Always, it is a treat to listen to you always, in spite of technical difficulties.
Yeah.
Thank you so much, sir, for the excellent session on the role of ultrasound and placenta accreta syndrome. Thank you so much, sir.
Thank you very much for the wonderful session, sir. This is followed by a small message from our educational partner. Next is the most awaited session of the day, the panel discussion. For the panel discussion, I would may request Professor Hepzibah ma'am to invite the moderator and the panelists.
Yeah. Good afternoon, everyone. It's my privilege to introduce the well-renowned moderator, Professor Girija Var. He is Professor of Department of Gynecology in Bharat Vidyapati Medical Hospital, Senior Consultant, Cloud9 and Apollo Hospital, Faculty Professor OGASH International Experts General Coordinator. She is Chairman Medical Disorder and Pregnancy Committee of FOXI, Vice President India Chapter Justosis, Member of Governing Council of ICOG. She is a Joint National Secretary of FOXI, Assistant Coordinator National Eclampsia Registry, Member Central Supervisory Board of the PCP and PP Act, National Mentor of Laksha MOHFO, Government of India. She has received the prestigious award, Anandi Bhai Joshi Award for Excellence in Medical Services. And I'm happy to introduce the panelists also. We have an eminent gynecologist, fetal medicine specialist, anesthesiologist, and a neonatologist. I'm very happy to introduce Karpahamol Saira. She's a consultant obstetrician, gynecologist, and fertility specialist. And she's a recipient of AICC RCOG Traveling Fellowship in Gynec Endoscopy. She has presented many paper posters in various national and international conferences. She is right now she's a consultant in the Kaveri Hospital, and on Sundays we very often see her in all the marathon, either in running or in cycle riding. Next slide. I'm happy to introduce Selva Priya. She's a fetal medicine specialist, director of Spring Fertility Fetal Gene, and clinical director of NDJH Gift Fertility and Fetal Medicine Center. Right now, she's a secretary of Nagarkoil OBG Society. Next slide. And happy to introduce our adjunct faculty, Dr. Deepthi Jamai. She's a director and fetal medicine consultant. She's got a lot of awards to her credit. She has won an award for Best Oral Presentation at USO Delhi and a poster presentation, a gold medal for Best Oral Presentation and US Con Mumbai. Right from her college days, she always won a lot of gold medals. And happy to introduce our own faculty, Associate Professor at Savita Medical College, a consultant anesthetist. His field of interest in pain relief. He conducts a fellowship in our college, and he's always keen on conducting a mini workshop in ultrasound guided regional anesthesia across the state. He has written a book on ICU management. And pleasant to introduce Dr. Lakshmi, a neonatologist. She's a head and consultant, Department of Neonatology, Neta Hospital. She's secretary of PNNNFO, and she's an examiner for National Board Examination and MGR Tamil Nadu Medical University. And she has authored 3 chapters and she has got many publications. Over to Dr. Girija for your panel discussion.
At the outset, I'd like to thank you for having me here, and with such wonderful presentations that we had. I think our panel is next to done, but all the same, as Madam Hepzibah has given us an important responsibility of converting whatever we discussed now into a sort of a best practice recommendation. And I'm really glad to be here on this forum to be discussing this in a practical aspect. I congratulate the fetal medicine unit of the Department of OBGYN of the Savita Medical College for having this wonderful plethora of great talks which are going to help us evaluate and enhance our practices in a much better way. And I really want to congratulate Dr. Malti and Dr. Sudarshan for their wonderful exposition. Of course, Dr. Tony Tan is always a treat to hear, the maestro himself who has done so much work on preterm deliveries. I'd like to welcome the panelists here, Dr. Karbagambal, Dr. Dipti, Dr. Selva Priya, Dr. Prem Kumar, and Dr. V. Lakshmi. And as we start, I would like to quote Winston Churchill, a personality who I really respect a lot. Is to improve, is to change, and to be perfect is to change often. And I'm sure that all of us who are participating in this panel will definitely take away some very important messages from our expert panelists who are going to discuss this today. So we quickly move on to the cases. And the first case is Mrs. XYZ, 28 years, married for 2 years. Body mass index is 35 kgs per meter square. Hypothyroid, mild anemic, pre-diabetic. She had a first missed abortion, and now second time she has conceived with ICSI, 26 weeks severe early onset preeclamptic toxemia, has IUD, abruption, and now landed in HELLP. And after that, when she was delivered, she had cardiomyopathy after 1 week of discharge. I would like to pose my question first to Dr. Karba Mangal. And I understand that Madam is a fertility specialist. I would like to ask you, what are the various risk assessments which you would consider before embarking on getting into a pregnancy with this particular patient? What would be your approach? Because I would feel that after a missed abortion, I understand 5 to 6 weeks missed abortions, usually we do not think that it is thrombophilia. But then such an event has occurred before we get on into something like an ICSI. It is definitely a very, very sort of, not only a very stressful kind of a, hey, for the doctor as well as the patient. Are there any such risk assessments that you would consider? And what would be your guidance to all of us? Yeah.
Good morning, everyone. As Madam was asking about the risk assessments, we have this FOXY GCPR, Good Clinical Practice Recommendations for Hypertensive Disorders in Pregnancy, called as Gestosis Score, which is a very important score that we need to assess for each and every patient. Actually, the score has risk factors points like 1, 2, and 3, and all the various factors are given there, and we have to actually plot the score, and if the score comes as more than 3, definitely they are at risk of the preeclampsia. So considering this clinical scenario that is given here, the first point is BMI. BMI more than 35 definitely is a risk factor. Hypothyroid is not considered a risk factor according to the Gestosis score. Definitely there is pre-diabetes is a risk factor, and even though we don't consider one miscarriage as a very clinically significant, because we know 1 in 6 pregnancies miscarrying, and especially in elderly age group, because of aneuploidies, the miscarriage risk is more common. But still, the second pregnancy history, IVF conception, conceived ICSI at 26 weeks, which is very, very typical of some underlying medical condition. I could be an antiphospholipid syndrome or a connective tissue disorders like systemic lupus erythematosus, and we need to evaluate her for this condition also. So definitely, Madam, Gestosis score has a very, it's a very important and clinically relevant score that needs to be charted for this particular patient, Madam.
Absolutely. Thank you, Dr. Sairam, for getting into all the wonderful things. As I think a lot of our focus is now moving on to understanding what is called as pre-pregnancy optimization, because it's not only about avoiding the complications in such a young person. You can see she's just 28. And in a second pregnancy, that's the first pregnancy which she could take a little forward. She's landed in cardiomyopathy. And therefore, you have given us a wonderful message that we have to look at all these factors before we embark upon anything that is interventional, such as an ICSI. And this would also be under consideration whenever we are looking at the age groups and simple things which would come into the Gestosis factor. Because we understand that even a short maternal stature and an obese woman, as Madam said, would definitely cause in issues. Are there any ways in which we can optimize this? Because we are having a lot of obesity in our community. We are having a lot of women coming to us with infertility, polycystic ovarian disease, high, increased insulin sensitivity. So can we do something for them? Dr. Sairam. Yeah, Dr. Selva, you would want to answer this question?
Yes, Madam.
Yeah.
Madam, knowing the Gestosis score and also knowing the importance of all the small things, like how you said, the age, she's just 28 years and everything. If we can catch these kind of patients in the pre-pregnancy time and do a proper evaluation, obesity is something you can give advice for hours and hours together, but the particular practitioner must have proceeded with ICSI in spite of the BMI being 35. Usually in the European countries, the standard is before ICSI, you have to maintain them in a proper BMI. In our country, we are not able to catch them in the pre-pregnancy state. If we are able to catch them in the pre-pregnancy state, or suppose she had a missed abortion, then and there only she should be told that please come after two months. You have to be evaluated completely. There is already certain risk factors associated with your issues. So catching them in the pre-pregnancy state will alone be the best way to prevent possible complications in the subsequent pregnancy.
Absolutely. Thank you, Selva, for that excellent message. And there are evidences which are seen, because I can see both of you are extremely fit young obstetricians and they can be role models to your patients, that physical activity, taking folates, folic acid, optimizing the hyperinsulinemia definitely gives a lot of credentials in reducing these particular incidences and occurrences. And we cannot disregard dyslipidemia, because we are a patient, we are a community of high Asian ethnicity. And as Dr. Selva said, that weight has to be reduced. And if you look at the Indian body mass index, to cut off as an obesity is 26 BMI. We are not talking of 30, we are talking of 26. And Dr. Sairam, I am sure you would like to add something upon this, looking of being a marathoner and something as I added from your CV. So are there any quick fixes which we can speak to, because patients in our country are extremely desperate to have children? So there is a short kind of a window where they can work in. So can you speak of any percentage on which you can guide them, that maybe this percentage weight loss would help you to have better outcomes or anything like that? Yeah.
Usually I'm very much positive in terms of weight loss, because I tell them, whenever I talk about weight reduction, everybody is very upset, because every doctor they go to, whether it's a physician or a cardiologist or an orthopedician or a gynecologist or an obstetrician, everybody asks them to reduce weight, and it puts a lot of mental stress on them. They know that they have a higher BMI. So what I would suggest is, I would ask them to take simple steps, use very simple steps, like ask them to reduce at least 5% of their initial body weight. That will really make a lot of difference in the incidence of decreasing the incidence of complications. First thing I would tell them, and I definitely would ask them to go for a very good, balanced, healthy diet. That is very, very important. So only exercise doesn't help. It always has to go along with a good diet. So those are the two things I would always encourage them. And definitely folic acid supplementation along with B12 supplementation will also help them in during the pre-pregnancy period, will also help them in having a healthy pregnancy. So my point would be, I'll go in a very short steps. Suddenly I won't ask them to reduce 20 kg or 30 kg. I will ask them to reduce.
It's impossible also.
It's impossible.
It's not going to happen.
Yeah.
So they get very upset mentally when we tell them about weight reduction. First thing is, so I mean,
first thing is they change the doctor. They go to somebody.
Correct. Very true, madam. Very true. They go to somebody else.
Madam, and there is one more concept of this mommy makeover clinics which are actually shooting up. We as obstetricians, we take care of the antenatal checkup. We are responsible for the mother and the child. But all the supportive things, it's becoming all the physical exercises they do, the food they eat, like how doctor has mentioned, Kapagamba, she's mentioned about the diet and everything. That comes as a separate package, and they are followed right from the beginning, from pre-pregnancy to pregnancy to post-pregnancy. If the mommy makeover clinics are coming, we can cover a lot of these things, because sitting in the clinic, we can't really talk about this weight reduction. But to an extent, you can leave a word, 5% reduction is going to help you. But like how she says, we can only say that. To put it into action, the makeover clinics will really help with especially high-risk pregnancies.
Absolutely. But what I agree to you, Selva, is we can, like, if we are outsourcing doing blood pressure to our nurse, we can definitely train people and have some sort of a connection with our own, because sometimes I'll tell you, Selva, this nutritional guidances and all may not be scientific. If you are associating and partnering with them and guiding them,
we have to.
Yeah, we have to do it. Absolutely, I agree to
because there are apps available. Patients can go anytime into the apps, but like how you say, the doctor's knowledge should be completely incorporated into the makeover. Otherwise, it's not going to be of any help for us. We can't manage the high risk.
So one more vista which would open up, and I would like to get Dr. Lakshmi on board, who is our neonatologist. We have a window of pre-pregnancy optimization that we are discussing, Dr. Lakshmi.
Yes.
Would you want to, we are talking a lot about Tdap vaccinations now from the Neonatology Forum coming in a big way. And I am a proponent of vaccination, and I feel that in the pre-pregnancy period, there are certain vaccines which can be considered. What has been your experience at the neonatology end? One, I want you to answer on in the context of vaccination, what you desire that the mothers get. And second, I would also like to ask you, when especially these babies are born with preeclampsia who go to your preterm births, my understanding as an obstetrician is Babies who are born with early onset preeclampsia pregnancies have less nephrons in their kidneys. This is our experience. And this is what has been understood. Would you want to throw certain light on this for us, please?
Thank you
Because
so
you are
much.
taking the end product of our entire pregnancy that we are creating.
Thank you. Thank you so much for including me in this eminent panel. Vaccination during pregnancy is picking up very well. We have made it mandatory to give a Tdap as well as a vaccine group for. I am just started dreading now. The July flu season is coming, and every giving a huge case series of RSV, epidemic, premature babies, and giving us a very tough time during the month of July and August. And most of our preterm, which with great difficulty, we take them along from 20, 26 weeks, and then we discharge them. They're back in no time with an RSV pneumonitis, going back to
Can you just give us a long form of RSV, because we are many
respiratory syncytial virus.
Okay.
RSV is respiratory syncytial virus.
We are doing a study in my center, but I thought my colleagues should know the long form of this.
Okay. So this is a big epidemic which occurs in July and August. More so, it attacks the preterm babies with viral pneumonia. They have a very stormy course, and we tend to lose almost 25 to 30% of them come a bit late. So it is very important that the mothers receive vaccine grip in their third trimester or prior to delivery, so that bodies are passed on to their babies, especially in the first 3 months. And especially if deliveries are going to be planned in April, May, more so take their vaccine grip vaccination. And now people are also giving and made it mandatory to give a COVID vaccination for the baby. So this answers your first question. And the second question, taking a preterm baby from 24 weeks, we started taking and getting them discharged out of the NICU is just the beginning of it. It's not the end of it. And yes, very recently I did a international nephrology conference, and where the nephrons, the size of kidney, and the GFR of all these babies who have either prematurity or growth restriction on prematurity, and that restriction, if early onset, has got to do with the nephron numbers and the kidney function. And these babies are landing up in end-stage renal failure by puberty or early adolescence. So you mentioned it, just discharging this baby is beginning of a big era. We keep them under monitoring for their renal size, proteinuria, GFR, hypertension till adolescence. That is the part of it. It's not only the kidneys, it has also do a lot with the lungs, because even before their saccular canalicular stage lung development, these babies have come out, and these babies' lung function is also much lesser, and they land up in COPD maybe by early adulthood also. So yes, we have to keep a very, very long-term monitoring on babies, because about a decade since extreme preterms of 24, 25 weeks are being handled. Wait for them to pass into adulthood to get more data on them. Thank you.
Thank you, Dr. Lakshmi, for that wonderful insight. And that is what I wanted to, discuss at the end, because we are talking of low age of viability. We are trying to talk of 500 babies surviving grammars, 600 grammars surviving. I think these are not our trophies, these are failures. And therefore, I'm now going to make a statement which I would like my panelists to correct or discuss about. I have a feeling that if you have such an opportunity where a woman has miscarried and come to you for her second pregnancy or otherwise, we can use that window of opportunity, one, to give her MMR vaccinations, because mumps, measles, and rubella all are responsible for miscarriages and causing defects in the babies. I would like to give even human papilloma virus vaccination to all these women, not only to prevent cancer cervix, but to prevent the viral pressure in a cervix, which can predispose to PROMs and preterm deliveries. And of course, to update her with COVID and hepatitis B, what is happening today. So I stand here to be criticized from my panelists and to opine on this particular act of preconceptional thing, which I've started practicing in the past 2 years. So yes,
I completely agree, ma'am, because I think over the past 1 year, once this COVID has set in, once the pandemic has set in, there have been two groups of people.
Yeah.
One, I feel that as a couple, I'm seeing plenty of couples who are walking in for preconception counseling, irrespective of whether they've had miscarriages, even if they're actually planning for pregnancy. I think there are a lot of information available on media, social media now. I think a couple, they want to come, they want to plan, they want to make sure that everything is all right even before they end up in their first pregnancy. And more so, if they've had miscarriages in the past, I think preconception counseling is picking up. I'm not going to deny it. And two sets of people, as I said, once the pandemic has started, is one set who have started working on their BMI and physical activity, and the other set where they've actually gained more weight. So both of them are there. We are seeing a mix of people. I think preconception counseling, for no doubt, is the era where is a phase where we need to comment on vaccinations. Definitely COVID vaccinations along with rubella, because as a part of our antenatal profile, we do rubella IgG antibodies. So I think if we do it prior and vaccinate them, nothing like it. I think that's extremely important to start them on vitamin supplementation, folic acid supplementation, vaccination, and correcting their BMI.
Yes, and now I again take this opportunity of asking Dr. Lakshmi to speak about the 1,000 days concept, what you want to say quickly, and any of my panelists to contribute to it after she finishes.
Yeah, it's an excellent concept. 1,000 days concept is the first 1,000 days of a baby's life from the time of conception to 2 years of age. The nutritional part is very, very important for optimal neurodevelopmental outcome. And so the neurodevelopmental outcome of a 2 years depends on the nutrition of the mother the day she conceives a baby. It is very, very, very important. And even now, the concept of neonatal nutrition has changed so much in the intensive care unit. A 24-weeker baby who's 600-gram baby is on nasogastric or orogastric expressed breast milk from day one. You have to believe this. Even a 600-gram baby and a 25-weeker is out day 5 to day 7 on full expressed breast milk.
Absolutely. We are doing it in Cloud9.
We are addressing the nutrition of these developing brains of the baby to give us a better outcome at 2 years of age. I had 540 babies analyzed just to say, no, it is not an easy task to get an breast milk from the mother from day 1 to day 7. You say the high-risk mother, an infertile couple, maternal age is little higher, they have multiple medical problems. Most of the time, what I witness is the mother is absolutely, the interest on the baby is almost very minimal by the time the baby delivers. She just wants to get done with it. Just leave me alone for some time. That much she would have undergone during her pregnancy. So we motivate other mothers to give express breast milk. We have a breast milk bank. We also have a pasteurized human breast milk.
Yeah, we'll come to that, madam. So we thank you.
So nutrition should be addressed from day one. Aggressive nutrition from day one is very, very important for optimal neurodevelopmental outcome. At 2 years is the 1,000 days they complete, 2 years of age.
So collectively, Dr. Dipti, congratulations, Dr. Selva Priya and Dr. Karpa, both 3 of you have mentioned that pre-pregnancy and before conception itself, we have to optimize health. And therefore, we would like to extend the 1,000 days window further beyond 100 days prior to see that the mother's health is optimized before she embarks upon pregnancy. And I want to share with you the fact that the Justosis score mentions about ART pregnancies a lot, because it has been found that even men who are azoospermic or oligospermic, they can contribute to problems such as justosis in a big way. And therefore this requires, and it's not only about the mother's nutrition, it's also going to be about the father's nutrition that we require to look into.
Yes.
And while the Justosis score was mentioning this in 2019, I must tell you, friends, that the ACOG in its recent recommendation of 2020 started mentioning assisted reproductive technology as one of the most important maternal factors. And I would like Dr. Karpa to comment on this, please.
Definitely, madam.
I'm calling your short name Karpa because I'm finding it easy.
That's fine, madam. So basically, definitely ACOG also recommended ART conceptions pose an increased risk of preeclampsia. So as of now, we have actually studies which says that compared to fresh transfer, even frozen transfer poses a higher risk. The concept that they are coming up with is because of the absence of the corpus luteum in frozen embryo transfer, with the corresponding concomitant decrease in natural progesterones from the mother. So in frozen embryo transfer, we are actually supplementing with a lot of progesterone supplementation exogenously. So there is also definitely a risk of preeclampsia. Frozen embryo transfer has a higher risk compared to the fresh transfer. And in the Gestosis score also, it mentions about the short period of married life and also the primary paternity. So if she has actually conceived with another partner, there is a risk of preeclampsia. Also the male factor, ART conception. So all these definitely pose an increased risk of preeclampsia for the offspring. And we also have, as Dr. Lakshmi was also telling, we are also talking about what is called as fetal programming of adult diseases.
Yes.
Actually, what happens inside for the 9 months is more important on a long-term lifetime basis for the fetus, child, when the child is born and as an adult child grows.
Absolutely.
I definitely think that, ART conception, even with the third-party reproductions, even with surrogacy, everything has been quoted very nicely in the scoring points.
Absolutely. Thank you so much for that. And thrombophilia and autoimmune disorders have to be investigated. And what has been your experience? Because we are constantly saying we do not have the incidence in our country. And then when it is a 5.6 weeks pregnancy, we said, no, this wouldn't be the reason. Let's do it when she has 2 losses. Or maybe let's do it when she has loss after 8 weeks. Anybody would like to comment on this, please? Dr. Dipti wants to say something? Dr. Dipti? Yeah.
But I think seeing all like when we get the patients for nuchal translucency scan or anything after recurrent pregnancy losses, whether based on the research or not, I'm seeing increased number of pregnancies already started on ecosprin 150 milligram and low molecular weight heparin as soon as the fetal heart activity is diagnosed. So yes, once the antiphospholipid antibodies testings are done, either if it is positive or not, they're considered as seronegative aplas, and it started. I think over the past 1 year or so, I've had increased number of pregnancies who are on ecosprin and low molecular weight heparin, because the reason why I'm seeing it more is if these patients come in for procedures like amniocentesis or chorioamnionic sampling, I have to postpone the procedures for minimum 48 to 72 hours to stop that and then plan for procedures. So I would definitely say, irrespective of the evidence which is available, patients prophylactically, if not, what is happening is if we don't start them on ecosprin or heparin, another obstetrician is going to start them on ecosprin or heparin. No matter what, we consider this as seronegative apla and start. I guess this is how patients have been started even before they come for an NT scan.
Yeah, and then we do not know how to define the seronegative apla.
True.
So
true.
there we just have
The
one
true
ANS.
cases.
Yeah, we just have one ANS or ACA positive, and then everybody gets helter-skelter. And I think even before we tell them, the patient will herself start taking ecosprin, because COVID has initiated a lot of self-medication. Patients have become extremely smart because they probably had time at home. And these were one thing, one of the fertility specialists did share this with me, saying that they did not have COVID complications very commonly occurring in pregnant women. And she wanted to give attributes to probably ecosprin and like low molecular weight heparin, which the patients were on. I want to give attributes to flu vaccination, which I gave to my all antenatal mothers. And I think the reason why we are justified in giving LMWH and ecosprin probably in our patients is excessive sedentary lifestyles. Does anybody want to comment on this? Because that could be giving rise to pelvic thrombophilias and things like that, because whole lot of occurrence. I don't know how many of you have seen upper limb thrombosis is being presented in young women. Are there any such experiences from the down south? I'm seeing this a lot in Maharashtra and even in certain northeastern communities. Anybody would like to comment on this apart from what Dr. said? Yeah, Dipti wants to say something more. Yeah, yes, Dipti.
Go ahead, Selva.
Yeah.
No, upper limb, no, madam, not much. But sedentary lifestyle, it's something, the pampering. The pampering is increasing with each generation, and just doing our own work, like just folding the clothes or washing the clothes and just doing the normal household itself, it's considered as activities in the present world. They will come and tell you, we are doing all the exercises. What I do, cooking, I clean the house, I make the batter, the normal activities, the survival activities are considered as exercises in the current world. And yes, madam, a lot of patients, you see that excessive weight gain in pregnancy because of the sedentary lifestyle is definitely increasing. But Deepti, are you seeing the upper limb
No,
thrombophlebitis
not
like
the
what,
upper
madam?
limb. What I was to say, 2 weeks earlier, there was a young, like 29-year-old, 29 to 30-year-old who started on oral contraceptive pill, and she ended up with thrombophilia. That was the first case. Her BMI is around 31. She ended up with thrombophilia just with an oral contraceptive pill. That's it, just to regularize her period. She was not planning for pregnancy. So how significant it is to start a normal routine oral contraceptive pill and to end up with thrombophilia. That was a huge.
I think there has to be a lot of red flag assessment done before we start the combination of estrogen and progesterone. Sometimes there are family histories which are telling us about stroke and all, which we do not take cognizance about and land in these problems, because I feel we should not encourage this thinking too much, because contraception is a big need in our country and oral contraceptives happen to be extremely valuable, and then they are not being taken because there's a lot of fear about it. Likewise, the other problem that we are coming up with, thyroid hypofunction, and it's too much on the rise. Anybody would like to comment on this? How should be your, would you like to screen all women getting into pregnancy before preconceptional or definitely in the first trimester?
And we are doing regular thyroid screening, madam. We'll be very happy to catch them in the pre-pregnancy, which doesn't happen. But once they come to us, we definitely, thyroid evaluation, I think almost everybody here will agree that we are doing it on a regular basis. Everybody.
Apart from preeclampsia, it's not only about preeclampsia, it's about fetal hypothyroid, fetal cretinism. I want to catch the mothers early before even the fetus starts its own thyroid gland synthesis. So I think thyroid, definitely, there's no doubt about it.
So that has to be universally done with the rising thing. And I think all of us are using 3 as a cutoff to say that she is hypothyroid and taking upon from there. And thank you, Dr. Karpa, for bringing about the Justosis score. And I would again reinforce and say about this, I'll definitely send a flyer about all this score in detail, which talks about so many factors which are not mentioned in any of the SPRE studies and all those studies from the FMF Foundation, which have come up, which are talking about specifications. And this would be of great help to us, because not all of us are blessed in our practices with fetal medicine specialists like the ones which I'm seeing on the panel here. But therefore, making this score and then segregating these patients. Okay, now this is a patient who has to go to Dr. Selva, or this is the patient who has to go to Dr. Dipti, would help us in screening these patients better and avoiding this. And this is just a screenshot of various kinds of risk factors that have been considered by ACOG, NICE, SOGC, SOMANS, ISSP, and the WHO. And we at the Justosis score have made many factors coming in there. And I think this can just help us in at least making our antenatal care a little more focused on looking at the woman's thing. And that is the rationale what we explain. Now, coming to the fact, we had a wonderful presentation from Dr. I think who was the first speaker today, and they spoke, Madam Malati spoke wonderfully about the uterine artery pulsatility index, and it's, sort of the way and the mechanism of how it's measured. Dr. Selva, would you like to give us any tips of doing this uterine artery PI in a better way, context preeclampsia? Because sometimes, we'll end up sending patients to you at 11 weeks. My own sister is a fetal medicine specialist, and I'm really blessed. I always say thank you to God every day in the morning for having her in my life. But then she has taught me that please send your patients, don't send at 11 weeks. Please send them exactly after you cross 12 weeks. What is your guidance, Selva, here?
Madam, usually when we are doubtful about the patient, like if they have a previous history, we start doing all this uterine artery Doppler earlier. Because even if we don't start, like how Deepti said, the empirical use of aspirin is going on. They come with aspirin. You sometimes even your Dopplers are not going to give you the right thing because they're already taking Doppler. It's a pseudo thing. So the first, we are happy if they are coming to this pre-pregnancy, and second, as early as possible, if we know that some factor is there. I think I won't even wait for 12. I need to specifically ask them, are you being prescribed aspirin? Are you taking it as early as they just see the precard and they start taking aspirin because they're already aware with the previous losses they know and they start taking. So that should be the first question. Are you already on aspirin? So we need to know it earlier. In case, and like we receive cases mostly at 12 weeks, madam. It's unfortunate we don't get it earlier. You know, they finish the just the confirmation will be over. We get it at 12 weeks. So most of my patients I'm starting to see only from 12 weeks, like when I start the NT scan, because I'm not doing obstetrics, so I get it only from 12. So as early as I see them, the first scan, I'm definitely going to go for the uterine artery. It's a routine thing. Previously only in doubtful cases, now it's routine. Along with the NT scan, you're going to do the uterine artery Doppler, and that will definitely give us a clear idea.
Absolutely. One more thing which I wanted Dipti to throw a light on is which would be the patients where you recommend doing a transvaginal Doppler, because I want this to be a very clear message. The moment we confirm a pregnancy at around, let's say 6 weeks, patient has done a sonography, and then we should not allow her to get lost to the follow-up. I think we should from that time itself calculate her expected date of the first trimester screening and write it in a prescription and tell her, this is the date you're going to come, maybe a range of 3 days, that you're going to go to Dr. Dipti or Dr. Selva and get your uterine artery PI done if I'm not doing it for you. What is your guidance, Dr. Dipti?
Yes, ma'am. I think the reason why we prefer 12 weeks is that not everyone, like as you rightly said, not everyone dates the pregnancy as early as 6 weeks. So if in case there is a delayed conception, and if they end up with 11 weeks, the patient, to get the patient back again becomes very difficult. So that's probably the reason why 12 weeks plus is taken as the cutoff. Not only for that, the CRL after 12 weeks is 5 centimeters. So when it's more than 5 centimeters, for me, sonographically, it is better to see the baby. The CRL is more than 5. I can see the nasal bone well. I can see the NT more clearly. And not just the nasal bone and NT, we do many other structural evaluation, fetal structural anatomy. So probably that one point which I wanted to make sure, that's the reason why we prefer patients to come to us after 12 weeks. 1. 2, yes, routine uterine artery Doppler screening is done. I would comment on 2 things. One is transabdominal and transvaginal, as rightly pointed out in the screen. The reason why transabdominal, it requires a particular partly filled bladder, not overtly filled, because if it's overtly filled, you might tend to put a lot of pressure on your transabdominal way. So both ways, however it is, there's a lot of prerequisites which is required before a transabdominal scan. Whereas in a transvaginal scan, you can easily visualize the uterine artery. It's easily visualized because as the pregnancy advances, probably in a second trimester, transabdominal ultrasound would be more feasible and easier when compared to a first trimester. But if you're concentrating on a first trimester, transvaginal ultrasound fetches you good results. And if you're using a transvaginal ultrasound, please take the cutoff for the transvaginal ultrasound. Uterine artery PI, that's extremely important because there is a difference between transabdominal and transvaginal cutoff, and we need to plot it either in a graph which is available in Fetal Medicine Foundation for free. So I think a partly filled bladder for a transabdominal ultrasound, if in case you're not able to do it, transvaginal is the best way to go for a uterine artery PI in the first trimester. And no empirical treatment based on uterine artery Doppler alone. I want to stress on that also.
Yeah.
There are 2 resource settings, low resource setting. Not many people could be affordable for a PLGF, but uterine artery Doppler with a mean arterial pressure, you have a significant history in the prior pregnancy. I think that gives a lot of hope. And now anyway, we are doing beta HCG and PAPA. But if they are affordable, yes, PLGF, plenty of patients nowadays are going in for preeclampsia screening. And then I think the sensitivity is high only when you include all the 3 parameters. Mean arterial pressure, your uterine artery pulsatility index, along with PLGF and other factors. So no empirical treatment based on uterine artery PI alone.
Absolutely. So that is a wonderful message that you've given us. I would like to add your gamut of TVS to be obese patients. There are a lot of obese mothers where transabdominal scan would be extremely difficult. And Dr. Karpa, coming to you, she did mention about only looking at the uterine artery PI is not right. What is your opinion about the PAPE cutoff? Because 0.03, I am seeing in my practices, we are doing a huge series of about 1,500 patients we have under the ICMR flagship project in my university where I'm the PI. We are not finding PAPE to be at all useful in risk assessment of preeclampsia. You have any opinion or anything on this, please?
Yes, madam. See, madam, I do routine first trimester screening with combined screening and also uterine artery Doppler. For high-risk patients, definitely if the history indicator or any previous history, definitely I would like to get their preeclampsia screen as well. So mean arterial Doppler plus PAPE and PLGF. So what in my clinical practice on a routine scan, I do uterine artery Doppler, and as Deepthi said, we can combine with the PAPE score also and the BMI also. So what I would say is many times when the PAPE is less, it also skews the result of the FTS screen. So when the PAPE is less, I have seen few patients who have had preeclampsia and oligohydramnios, and growth restriction. So I would start them on equaspirin if the PAPE mom is less than 0.4, madam.
Absolutely. Okay, so that would be your takeoff. We'll give a little importance to it. Yes, we tend to, my advice to everybody is please don't scare the shit out of them, because many times patients are so scared. I've had patients saying, PAPE has come less, madam. I've been told that I'm going to get eclampsia. It's a huge complication. Please give them nutritional guidance. Tell them something, tell them that there is a window of opportunity which is going to be open till you become 16 weeks pregnant, where we can make a little modification. And I hope you agree to me to this. How many of you are using the SFLET PLGF ratios in your practices, not only at the first trimester window, but also patients who have started having now 140/90 blood pressure, little bit of proteinuria. You want to make a no proteinuria, you want to make a decision, abhi kya karu main kinds. Are you using this in your in Chennai, SFLET PLGF?
As of now, I'm not using this ratio for risk assessment of preeclampsia, madam, because actually with the present clinical scenario, we are actually quite comfortable with the history-wise screening as well as PAPE as well as uterine artery Doppler combined screening. So I'm not using it in my clinical practice.
So we are happy with Madam and Selva helping us. Yes, anybody, Selva?
Madam, there is one trick about all this screening, madam. Even though we do a screening and even though we predict, okay, you are safe and you're not prone for preeclampsia according to the screening, another 4 weeks or 6 weeks, we are going to see something else popping out. So the screening is not the ultimate solution, because I'm from Nagarkoil, it's Kanyakumari. So there, if I suggest them more and more screening, telling them, see, if I do this test and if I see this ratio, I can find out if you'll get preeclampsia or not, and the report comes normal, and the same patient, they come back to me after 6 weeks that they do have PP, they've started taking medications, and I don't actually have answer for that. So I will go with Karpagambal, madam, because the history and how the fetus is responding, and like how Deepthi said, not just one time if you see the uterine PI high and you can't jump into conclusion and say she's going to be preeclampsia. It's very tricky. The sequential scanning is the best part, which is going to help you, because one scan is not going to determine the entire pregnancy. And the one more, I shouldn't say that, but if the same doctor, if the same protocol, if the same person is seeing the patient regularly from the first to the beginning, the chances of catching anything is possible. Absolutely. It's easier. I think you will, if I do the scan from the 12th week to 36th week, there is a lot of chance that I can pick up more, because the trend is, I have to say, we are all my friends, so I can say, see, obstetricians, we all do the antenatal checkup. The antenatal checkup is done by the same obstetrician right from the beginning till the end. But if you see the sonology report, they will be just window shopping. Each time they go to one place. So what happens is sometimes we lose a little bit of the track in finding out the small things. So I've been in a lot of tight corner whenever I have told them I've screened everything, all the double marker, triple marker, penta screening, everything is done, you're safe, and patients have still landed up with issues, and it becomes very tough to explain them. So sequential scanning and catching them early is even easier rather than sitting and talking about the prediction. Of course, it
There are the
helps, but
challenges which we have in our practice, because if we recommend a particular fetal medicine specialist, they would feel that we have some financial nexus with that particular person. And therefore, it's very difficult to tell patients. Patients come telling me, no, that doctor is related to me, so I want to go and do her. I said, just go, but please get the report, and I will have certain issues while interpreting. Doesn't matter. So we have to be, socially acceptable, and there's so many issues in that. And that was a good point you brought about, Selva. PLGF is also being proposed by one of the labs, and this is where I want to draw your attention and guide us, is as one of the, now they're calling it as a triple test, which can be done at the time of 12-week screening. As Dr. Dipti said, that we would like to do a composite thing, where they are doing the combined testing, which we used to call as PAPE, beta HCG, uterine artery PI, and the NG. Along with that, they are doing now the PLGF, which is being called as triple test, adding to confusion. Because the triple marker test, which we were doing previously, we have decided not to do it anymore because it doesn't validate in our Asian population. So what is your take on that? Should we make PLGF as a part of screening? And I agree to Selva, do whatever in the world, and to Karpa, that she says that look at the clinical factors, and we really do not know what's going to happen. So Dipti would like to say something.
The thing is, the only point here is the cost. I think we are screening patients. The ultrasound is one part of it. And the lab cost, when you include PLGF, I don't want to exaggerate it, it is definitely about 2,500. So if a patient is going to shell out in the first 3 months of her pregnancy, a minimum of 4,000 to 5,000 rupees, it becomes a huge, the point of us predicting a preeclampsia is to start ecosprin, 150 milligram at night. So that is the main point here. But that's the ideal way to go about it. Yes, we need to do everything together along with PLGF. We get a risk scoring, and early onset preeclampsia, less than 32 weeks, you start on ecosprin. But the patient side, many people are affordable as, yes, they are doing it, but that not everyone. In the low resource setting, if you charge them sky high, the next question what they ask us is, what are we going to do with the report? They said, we're going to start you on aspirin 150 milligram as early as 12 to 13.
Look at the
this
cost.
is the point where we are facing an issue. Yes, PLGF is still not cost effectively available at least in South India.
No, even here in Pune, it's very difficult to source it. That is one. And secondly, the only reason would be that patients are Googling, they are reading a lot of things. They should not feel that your doctor is some Gisa-Pita doctor, doesn't know anything, is a medieval thinker. One, and anything that comes in print, then they understand. While you're talking and telling them that these are your risks. But split PLGF ratio has been found to having a sort of a important place where you had early onset preeclampsia, and you now want to make a decision how much I can extend the expectant management beyond this particular timeline to ensure that there will be a safe delivery for the baby as well as the mother. Likewise, we have the glycosylated fibronectin, which has come on the foray, which has been validated in our setting, and that can also add value to this. But as we said, there is something that really requires some more testing of time and testing of money. And therefore, we discussed wonderfully that there are benefits of screening, which would include a prompt action, as Dr. Dipti said, but there are also potential harms from screening, which may lead to unnecessary anxiety. And we as obstetricians and clinicians have to balance our patients' thinking between this. And this is what we propose, that screen all patients with the Gestosis score, which is a clinical score with few emerging factors. And then definitely do a uterine artery pulsatility index universally. Dipti, what would you say? Universally in all your patients, ideally.
I think it makes a lot of difference.
But some of us are practicing in such places where uterine artery PI and such expertise as Dipti and Selva would not be available. In that situation, we may consider starting them on low-dose aspirin. And then if the risk score is found to be more than 3, then insisting that they undergo a proper surveillance during pregnancy, which would not only include their checkups on a regular basis, but weight modification, dietary supplements, and so many other things, and teaching them about alerts. So now coming to our second case, we have a missed abortion, 10 weeks DNE done, and she had anemia at that time. Anencephaly at 19 weeks of scan, which was terminated. Presence pregnancy scan at 6 weeks scan. She was scanned at 6 weeks, then was scanned at 19 weeks, where the cervical length was 3 centimeters, and still a cervical encerclage was done. And that time the uterine artery Doppler was already showing an increased resistance. Her periconceptional hemoglobin was 9 grams per deciliter. And then this patient presented with 27 weeks with diazepam and transferred. I'm sure you must be experiencing all these patients very well. The reason I brought in this patient was I want you to quickly talk about what could have been done better in this patient. Anybody can take this question. Karpa, you want to speak on this?
Yeah, definitely, madam. See, the first point is history, Mr. Miscarriage at 10 weeks, and second one, anencephaly. This can be a sporadic problem. And the patient, whether she was taking preconceptual folic acid and B12 is very, very important for the prevention of neural tube defects. I would really emphasize on that in this situation. And the second one is now in the present pregnancy at scan at 16 weeks, she had a cervical length of 3 centimeters. And I'm not sure why cerclage was placed. I wouldn't be in a position to do a cervical cerclage. And I wouldn't consider this as a second trimester miscarriage because this does not come into the history of preterm cervical cerclage indication. And also the anencephaly is mostly neural tube defect, mainly neural tube defect. And uterine artery Doppler showing increased resistance. So I would always see it's around uterine artery Doppler at second trimester. We have a cutoff range, and I would really ask them whether what is the mean uterine artery Doppler. And here, other thing that needs to be addressed is anemia. So in this situation, and the patient history is very important, whether she was a known epileptic, what was the epileptic medication she has been taking, whether she has been a neurologist for the fits. So those are the things I really would like to consider in this situation, madam.
Absolutely. But I wanted to just ask you, does this come to your mind that maybe there could be an MTHFR gene abnormality here, looking at the fact that she had a missed abortion at 10 weeks, then anencephaly at 19 weeks, and anemia generally? So are these things to be looked into? Like, should we do a thrombophilia screen in this patient?
I mean, I wouldn't be in a hurry to do a thrombophilia screen because there is the history for the first miscarriage and the second termination is totally different, madam.
Yeah.
Totally different clinical situations.
And how many of you would give diazepam for seizures?
No, nobody. We don't give diazepam.
Yes, we would definitely first go and give magnesium sulfate. So that was the message through this, and anemia, as you said. And you can see that this patient presented with such a severe malady that she had HELLP. The baby's weight was only 770 grams. Creatinine was always already 1. She showed LDH of 2,500. So she was already brewing onto this disease from 19 weeks, probably. Nobody understood, and she landed in this problem. So we have to be very, very conscious, and that's a wonderful message you gave us, to be looking at anemia carefully. Now, I would like to call upon Dr. Lakshmi, madam, here to share our experience with you about these 100 cases of peri-viable preterm births that were born. And this is also for my obstetrician colleagues. And we decided to analyze all these babies who were born from in the low age of viability. That is, ones which were born from 20 weeks to 26 weeks of gestation. And these are those 100 babies who were born. And look at the probable causes. You can see 13 had abruption, then 8 had prom, 12 had preeclampsia, eclampsia 2, and preterm births were 7. And what is that I want to bring about here is that we have to understand the amount of perinatal morbidity and mortality that we are pushing into with preeclampsia, which requires to be looking into attention, because these are the ones you can see APH, preeclampsia, eclampsias happen to be the commonest reasons why this baby would be born. So therefore, as Madam Lakshmi did tell us, that we have to be very careful with these babies, because these babies are definitely going to push in a lot of morbid populations ahead, and there are going to be issues further on. What is the survival on an average pan country for these babies? Because as we are going ahead, those columns are telling us that even smaller babies are surviving. And that is tempting us to do C-sections and delivering them so that we can have fetal outcomes. So what is your guidance on this, Dr. Lakshmi?
Yeah, the limits of viability, if you look at it, still, if your country can offer 50% survival for a particular gestational age, 50% intact survival or a long-term survival, that is the limit of viability. This limit of viability, it varies from country to country. Even Japan offers 22 to 23 weeks, whereas UK goes by 24 weeks. So it depends on your health infrastructure. It's just not a private institute or a corporate hospital which offers survival for 24 weeks. Based on that, you cannot push your limits of viability. The National Neonatology Forum of India, they say that if the baby has completed 25 weeks of gestation, we have to offer resuscitation in the labor room and proceed with treating such babies. Suppose we get a lot of pressure from the infertility clinics to resuscitate or take on a 23 or 24 weeks, we have to have a long counseling with the parents. Let me tell you the reality.
Absolutely.
26 to 27 weeks, we are able to give a 70% survival. But the course in the hospital is at least 10 weeks, and the cost in a private hospital is 8 to 10 lakhs. What time and again we find is first week goes well. By the end of second week, the parents want to push off to a government facility. They do not complete their treatment. Again, I want to reiterate one fact that obstetric colleagues or the infertility friends should consider is they should be prepared to spend for the baby also when they are going in for an infertility treatment. The time and again the answer we get is we have already spent 10 lakhs on treatment. We can't afford anything more on the baby. So when a baby lands up in the peri-viable period of 26, 27, 28 weeks, they are totally off guard and they are not at all prepared. So by viability, I have to say, I give more than 50% of intact survival for 26 weeks and above. So I'm happy to take 26 weeks and above after doing a detailed counseling, because I'm not for sending a baby halfway through to some other place, because the first 10 days is very, very crucial.
Absolutely. One more thing, madam, we want to ask you is antenatal steroids have been well proposed and we have spoken about them and we are giving them very, very efficiently. If not the entire dose, at least one dose we definitely give, 1 hour window we use definitely. But what about magnesium sulfate? Because the guidelines are mentioning that it has a very short window, while in our centers now and in my practices, I've started tripping it up even to a little lower gestational age, because there is definitely an advantage of neuroprotection. What would be your guidance at this point and what is the evidence?
Magnesium sulfate, when used in a preterm baby, many trials have shown to be the IVH rates are very less and the brain white matter injury is also very less. But in antenatal steroid, you have a window period of 7 days to decide whether this baby is going to deliver or not. But unless imminent delivery is there, magnesium sulfate is not being much used. No? When you use magnesium sulfate during preterm labor, you give a loading dose followed by 1 gram per hour or so for 24 hours. So unless there is imminent delivery, your magnesium sulfate may not be much useful, but neurologically, we have made it mandatory and we are using for all preterm labor. Just prior to deliveries, we are starting on magnesium sulfate infusions.
Yeah, one more observation is, madam, that magnesium sulfate, if you are given for neuroprotection, use at least a window of half an hour to 1 hour from the time given, finish the dose and then delivering the baby. Because sometimes these babies, they are not having any depression, but they don't cry. They just look at you.
We have looked at respiratory depression following magnesium sulfate. Most of them are already preterm baby. They'll have a lung issue. They will be on a CPAP in the labor room. So we do not find a respiratory depression to be a major problem with magnesium sulfate.
Yeah, sure. Thank you so much for that wonderful thing. I think we will have more and more guidelines coming in. Now we will go through this patient very quickly because we've already discussed these things. So I will not spend more time here. We will, there are many ways in which patients come to us with self-medication. That was that case. We move on to Mrs. AB, and she has had 2 recurrent pregnancy losses at 18 to 19 weeks of gestation. She had pre-gestational diabetes and then GDM at 12 weeks of the gestation, encerclage at 14 weeks, early anatomy at 16 weeks. Scan showed a 30 mm cervical length, and then history of indicated encerclage was done. She came to us for a TIFA scan at 18 weeks. And now again, her residual cervix is showing 16 mm of the cervical length. Now, Dr. Dipti will start with you first. Did something go wrong at 16 weeks? Why did the cervical length show 30 mm when she had shortening? You can just throw us some light there. And then we'll come to Karpa for this answer.
I think, ma'am, I think the history is very particular. I think it's an indicated cervical encerclage history, previous to pregnancy losses at mid-trimester. I think this is a perfect indication for a elective prophylactic cerclage. I think encerclage was done at 14 weeks. And in spite of cerclage, I think that the cervix is opened up now in the mid-trimester. And I think cerclage has been done at 14 weeks, is it not?
Yes.
Has been done already. In spite of that, it's opened up.
Yeah.
I think, yes. So the clinical history is very significant of elective cerclage. I think whatever has been done so far for her has been done in the right way. In spite of the cerclage, the cervix is opened up now at 18 weeks with 1.6 centimeters. I think more so, I think there are a couple of research papers which I found recently. We are combining both the vaginal progesterones along with cervical encerclage.
And there are German publications of the German.
So two papers where they have combined both together in spite of cerclage along with vaginal progesterone. I think the treatment for this patient has been done the right way. Unfortunately, so the cervix is still opened up in spite of cerclage, and I don't find any like sludging or anything in the funneling of the os. I think at least to a larger extent is it just opened up, but it's not in the worst case scenario.
So basically, I have a thing to say is that we also have to pay credence to not only the fact that there is a cervical mechanical strength, but I also feel that there's some factor like infection and inflammatory response which would come into being. And Dr. Karpa, would you like to comment on this?
Definitely, madam, this patient has had the right treatment for having a cerclage at 14 weeks. And actually, in clinical practice, I'm more comfortable with suturing with the Merceline tape. See, most of the cerclages that I have done with Merceline tape for the past many years have actually done quite well. And we know the cervix is a very dynamic organ. You know, we have had patients where the patient had a previous week scan of 3 centimeters cervical length, and the next week she comes with a open cervix. So ballooned out and bulging membranes. So we know it's a very dynamic organ, so we have to keep her under surveillance. So this patient who has had a cervical length of 16 millimeter, definitely I would like to do a high vaginal swab, urine routine for culture and urine for culture and sensitivity. And definitely many a times what I have seen is patients who are actually constipated. They develop recurrent urinary tract infections because they pass because in pregnancy, because of progesterone and other medications, they already they can tend to get constipated. So what I have seen is I prefer to ask them whether they are constipated and ask them to give them laxative supports. So in this situation where the cervical length is 16 millimeter, as Dr. Deepthi said, vaginal progesterone, or if I am worried about infection, I would also consider giving intramuscular 17 hydroxy progesterone weekly to keep the uterus quiescent. And also, I have actually used cervical pessary, Arabian pessary in my clinical practice, and definitely would like to try that as well, madam, because she's only 18 weeks now.
Yeah. So, what is your experience with the Arabian pessary? We would like to hear from you.
So, basically, Arabian pessary, I have used it in quite a few patients, madam. That is not my first choice. Definitely, my first choice would be a proper cervical encerclage. Then if there is funneling and if there is a short cervix, even after cerclage, when they are on surveillance, I definitely give them the option of pessary, madam. It's a very nice inert substance, which is very easily, and we have all the formulas or tabulations for the cervical length. Everything is given in the product manufacturer pamphlet. So
how much does it cost to the patient?
See, as of now, the cervical pessary in here, it costs around I think 9,500, 10,000.
And you need anesthesia to apply it?
No anesthesia.
Just do it in the operation theater.
Yeah. If you are doing it together along with the cerclage, it is not at all a problem because the patient will be under anesthesia. But I have inserted Arabian pessaries without anesthesia. It's basically inserting like our prolapse pessaries, ring pessaries.
Yeah. So I think time will tell us, and I'm sure you're accumulating your data and evidence so that we can use it with much confidence, because looking at the cost of 9,000, we should be sure of what we are doing. And in this particular patient, I'll tell you what I did was, I did a repeat cervical encephalage once again. And this time I did it sonography guided, because I wanted to be sure that I am taking it at the, and I could not take risks of doing the Shirodkar's stay, because I was not very confident. I thought that I'll unnecessarily tease the cervix a little more. Unfortunately, we took this patient to 37 weeks. One of the most other reservations which I had was giving her 17 OHPC in the context of a diabetes, that she has diabetes. So in this particular patient, does 17 OHPC matter? That's one. And secondly, later on, does it cause any hepatic, cholestasis of pregnancy? What is your experience, Dr. Kalpa?
17-hydroxyprogesterone caprolactate is a time-tested medication which has been used for a very long time, madam.
Yeah.
I don't routinely use for all patients. Only in special situations like this we give, and definitely intense monitoring of blood sugar. That's mandatory for even otherwise. So they will be on. Actually, they do a beautiful blood sugar profile weekly. So they bring the chart, and based on those values, we adjust the dose of insulin. And you see, even that progesterone has an effect on the liver function test. So, but in clinical, in my practice, I have not seen any patient who has been on 17-hydroxyprogesterone developing obstetric cholestasis. I have not seen any of them.
It's a theoretical risk that has been spoken about. And I think today, without OHPC or your natural micronized progesterone, women are coming with intracholestatic hepatitis because they are obese and they start taking, all kinds of things. So we do not know what's happening. Your point of constipation was extremely excellent. But secondly, also one more thing is gastrocolitis. I have observed a lot of gastritis which women have. Even that is known to contribute to such kind of abnormal flora, giving rise to shortening of cervix because of inflammatory processes. And I have sort of tweaked one formula that at around 12 to 13 weeks, I give them a kit, the azithromycin, secnidazole and fluconazole kit, and repeat it again at 26 to 28 weeks. Of course, this was my own patient, but still it didn't help. And we landed in issues. She was also on our most favorite Ecosprin for she being diabetic, but still she landed up in this. But then we were lucky enough. And as we have rightly told us that cervical insufficiency is not a mechanical disorder. It also is a conglomeration of a lot of other things which we require to look into. And therefore, that is the probable reason that cervical encephalage alone doesn't seem to be an answer to this question. We have to look at various other factors that are important because they can cause problems such as ascending infections, then the alteration in the flora that she very rightly tell us, anemia giving rise to inflammatory processes. So we have to start looking at it from all angles, looking into the fact that preterm labors in our country are very, very high. We have the highest number of preterm births all over the world. Now, has anybody got into this interesting reading which I came across, that there is some sort of a genetic abnormality which has been seen in the cervix in some women? It could be there prevalent or it could be acquired over a period of time. Dr. Karpa, could you just throw any light on this?
Yes, madam. Basically, cervix is a very difficult organ, whether it's cervical encerclage or not ripening and effacing in labor.
And whether Dipti has to see it on sonography. I'm sure she must be having challenges. Yeah.
Yeah. So basically, they say there is a problem with the collagen matrix and the muscle composition.
Yeah.
That is the problem in either it's encerclage, incompetence, or a cervical dystocia. So actually, some differences or genetic changes that happens in these kind of patients that leads to abnormal muscle to the collagen ratio in the cervix.
So I want to draw an analogy with that 1,000 days concept. If the mothers were weak in their mothers, if these mothers were weak in their own mother's wombs, did not take proper food or whatever, they may be having some sort of a collagenopathy, which must be a result of so many kinds of intrauterine influences, giving rise to weak cervixes. And so therefore we have to be sure about it. Now, when would be your direction of doing a cervical encephalage? What would be your ideal best practice? So we are talking of best practices. So what is your best practice of doing a cervical encephalage?
So cervical encephalage is history indicated. Definitely, if there's a previous history of the second trimester miscarriage, where other causes have been ruled out. So when I think it's only because of incompetent, the typical history the patient presents with no pain, there is sudden pressure, she comes and there is bulging membranes and she expels a baby. So that is the history indicated. The next is ultrasound indicated. Ultrasound indicated when we do a first trimester screening, we also look at the cervical length. If the cervical length is less than 2.5 centimeters, we actually don't scare them, because there are a lot of people who have had 2.5 throughout pregnancy and they have done well. Especially in primaries, when we see that, I don't even tell them, sometimes actually I have kept some of my patients on surveillance with a load of microdose progesterone and actually have carried on the pregnancy without a cerclage. So that I definitely would consider. And third is a rescue cerclage. So these are the cerclage types which I definitely follow in my clinical practice. So the rescue cerclage, definitely when the patient has come with a bulging membranes. And first thing I want to tell is the membrane should not have touched the vagina, because whenever we feel membranes are bulging beyond the external loss and have touched the vaginal flora, there is high chance of chorioamnionitis and PPROM. So I'm very clear that, I will tell them, because the vaginal membranes, when they have bulged out and crossed the external loss, I prefer not to suture them and, tell them, give them the grave prognosis for the fetus. And rescue cerclage, usually I do it with a nice head-on position, and I usually use a Foley's bulb to just gently push the membranes inside, and with the available cervical length that I could get beyond the membranes, the ultrasound guidance. Then that time ultrasound really helps in localizing the membranes and the liquor. So we do
and giving a little head-low position.
Yeah, head-low position with the head-on position. And we do a cervical cerclage with mercury tape and treat her for all infections, do a swab, urine routine culture, and keep her under surveillance. So that is rescue cerclage. So only 3 types of cerclages are present in guidelines, and I prefer to follow them as well.
So like you said, we did this particular cerclage, rescue cerclage for this patient, which is here, who's a 26-year-old diagnosed with thyroiditis. And then she was on a lot of things, and then she presented at 19 weeks. And fortunately, after a little bit of stabilization, we did it, and we could take her till 36 weeks of gestation. And you gave us a wonderful review of looking at the cervical length, looking at a closer surveillance, and then considering, and we can consider giving concurrent progesterone, either 17-OHPC or the vaginal progesterone, because the evidence is supporting it, if not fully, but at least to the tune of 35 to 40%. And the challenge, I'm sure, Dipti, what are your challenges which you can face when you are doing cervical length assessment at 16 weeks of gestation? Because usually that time, the lower uterine segment is not very well formed, and there can be certain difficulties. Can you just give?
True, ma'am. I think all our treatment is based on the measurement. If the ultrasound management or the measurement is not done properly, the entire treatment varies. So I think measuring cervical length needs patience. It's not just like you go in for 5 seconds and you just get the transvaginal probe. You need patience. As much as patient, you have to see the fetus and placenta and liquor, everything. Cervix is a dynamic organ, as Karpagama ma'am said. A minimum of 1 to 2 minutes, because I've picked up many intermittent funneling of cervix. So the cervix would be 3 centimeters. You would hold on the probe for minimum of 15 to 30 seconds, and you can actually easily see that the internal loss opening and closing right in front of you within 30 seconds and 45 seconds. So unless and until you don't put excessive pressure on the transvaginal probe, you insert it gently, and also try to avoid myometrial contractions, because myometrial contractions, many a times transabdominally, when you see, it will look as if the cervix is opened up. When you go in and see, the cervix will be quite long, more than 3.5 centimeters, just the myometrial contraction, which is right at the lower segment, which is actually showing up as if the cervix is open. I think initial protocol has to be a patient visualization of the cervix, minimum of 1 to 2 minutes. Only then we'll be able to pick up cases. And the linear measurement is very, very important. And you have to look where the internal loss and the external loss is. That's extremely important when you measure the cervix, and you need patience. I can't stress this much, because the 2.5 centimeters, as what Kalpagama ma'am said, 2.5 centimeters, we have pushed so many pregnancies just with vaginal progesterone, avoiding a cervical cerclage, because once you put a cerclage, it's in their patient's mind and the family that they have to be on complete bed rest. So if you can avoid a circle arch and she can actually move around a little bit, at least during her pregnancy, I think you can bring out a huge difference in her thing. I think cervical length measurement needs patience as much as you see the fetus and placenta.
I must confess to you that patient which I told you about, the recurrent circulage that I did, that patient was on bed rest till 36 weeks of gestation. And after that, when she got up, and this was unfortunate because we couldn't do anything about it. And this, when I made her get up at 36 weeks, I said, let's take out your stitch now. It's enough is enough. Let whatever happens. She delivered 10 days after that. She could not even get up. You know, their muscles become so constricted and contracted. It was so sad and depressing to see all that, because her husband used to get her in an ambulance to see me every time. Or once I had gone even home to see her, because I didn't want her to ambulate unnecessarily. So these are challenges which we are facing, and rightly put in Dipti that we have to be very careful and we have to have the right practice when we are doing this. Progesterone has been given a lot of attributes, not only causing quietening of the myometrium, but it also causes immunomodulation, anti-inflammatory actions, and therefore time will only tell us how useful it can be. And there are various options that we have. We had Tony Tan talking about it in detail, so we'll not go into it. And we also had Dr. Karpa Gambalan telling us about the wonderful surveillance that we have to look at and look at these patients correctly. And thank you for telling us about the measurements. Additionally, it's been found that low-dose aspirin has been identified to be a useful preemptive prophylactic intervention along with progesterone, which can help us in reducing preeclampsia, likewise calcium, preeclampsia, as well as preterm births. And calcium supplementations given as per the WHO guidelines are about 2.5 grams of calcium carbonate and 4.75 grams of calcium citrate. If you're using them, they are shown to reduce through a lot of studies and various systemic reviews to be useful. And especially in our country where we are having a calcium deficient diet, a calcium deficiency. Can Dr. Karpa tell us what would you call as calcium deficient diet? Because there's a guideline about that also. Quickly, I'm taking you off balance. It's whenever the dietary content is less than 600 milligrams per day is taken as a diet deficient in calcium. And therefore, it's important that we have a proper calcium guidelines. It should not be only from supplements, but it also should be from the diet that the mother has to consume. And thank you, Karpa, for giving us an insight about the Arapin cervical pessary. And there is basically about this, there is a randomized control trial. And therefore, it could be a useful thing to practice. And we are waiting for your results to tell us so that we can use this. You also spoke about asymptomatic bacilluria screening, looking for vaginal infections, bacterial vaginosis, constipation, general hygiene, and the pH of the vagina and high vaginal swab. Thank you so much for that. And then there are various methods and practices that would come into being to prevent preterm birth. Now, with this, we are coming to the last part of our session, and that is the abnormal placentation. And I'm sure that all of us are hugely worried about these kind of things which they occur. And we have our anesthetic friend here who has not yet come onto the panel. And I want to get him now here to tell us that many a times we have had such kind of surprises on table. And first of all, I think on behalf of the organizers and my panelists and obstetrician friends here, I am greatly grateful to you for being so patient all this while and keeping silent. So now we are coming to you. You have this patient who has, and this must have happened in your life quite often, that the obstetrician has gone and opened a patient in an emergency. And lo and behold, on the table, you find that there is an anterior lower uterine segment, richly formed new vessels of placenta accrete. And now she decides that, okay, fine, I'm going to do a classical C-section, and I may also consider doing a hysterectomy. What would be your role and what would be your guidance to us, and what would be your fluid managements, anesthesia managements? We want to hear from you.
Yeah, thank you, madam. Thank you.
Yeah.
And these sort of situations have really happened, and it's not like, even though it's not frequent, it does happen. And the most important thing as an anesthesiologist is giving confidence to the obstetrician who does that. And I think the obstetrician needs to have confidence on the person who's on the head end. Like instead of like themselves like seeing the monitors and getting tensed, I think it will be better that if they just concentrate with the field.
They trust you.
Absolutely. Instead of looking at the monitors or the anesthetist. So just have
scared. We feel maybe you're sleeping or you're talking to your girlfriends or something.
Okay. So I think till the patient has they can the most, I think the most important thing in any sort of abnormal placentation or patients who does have increased risk of bleeding is good communication. I think the head and the obstetrician and the anesthetist needs to communicate closely, and they need to have a constant communication about what they are seeing and what we are doing. So I think communication is the best way of doing it, and always it is like whenever we anticipate the blood loss, keeping when they like communicate, we just place all the invasive lines on place. We can do that very fastly, and if it's there in the prime time, it is always better to call a senior anesthesiologist in place. Always, it's better to have another person, so that it will be very grateful to manage such patients. And in fluid management, it is always like, other than the maintenance fluids, it is always like better, like we see the suctions and the gauze pads or whatever it is. We have our own ways of doing that. And but in the recent days, we have monitors like HemoCube, where we can just see point of care hemoglobins on table. Oh. And an ABG should always be in place, so that we can just see the hematocrit and decide on the blood transfusions. And it is always imperative, like any institution should have, any institution where obstetric care is being given, I think they should have a mechanism in place to activate a massive transfusion protocol. So 6 units of O negative PRBC, 4 units of plasma, and 1 unit of apheretic platelets should always be in place, and there should be definitely a mechanism so that we can get, once MTP is activated, I think they should get that in place at least within 10 to 15 minutes, because there will be definitely a time gap where we can always manage with colloids like yeast, starch, gelatin. So once we get that, I think it is very, very imperative, and it should be very logical that we should not wait for a cross-match blood at all in the table. We should always be ready to transfuse O negative blood. I think this is the place where most of the mistakes and tragedies does happen. So it is better, like we always keep this in place. And in the recent days, there have been point of care monitors where we can always monitor hemostasis. Hemostasis like thromboelastography, thromboelastometry, we call that as ROTEM and TEG. And with that in place, we can always find fibrinolysis, whether fibrinolysis is there, where clotting mechanisms are good, we can always find that. And what in the recent evidence, what we have seen is fibrinogen levels. Fibrinogen levels less than 2 grams per liter has been clearly shown that they are associated with a higher incidence of PPH. So irrespective of the surgical conditions, I think fibrinogen is very vital. So once MTPs, once transfusions are in place, if we still have a patient with coagulopathy, I think it is imperative to go either with fibrinogen precipitate or prothrombin precipitate or cryoprecipitate. Usually the biggest doubt is, most of the institutions nowadays we have cryo, where the dose is usually like 1 unit per 10 ml per kilograms. So once we have everything in place, I think we can always manage a patient who may have excessive or massive blood loss.
What as the obstetricians we normally do, Dr. Prem Kumar, is, if you have a patient who has low platelets, we definitely order for MTP, but we always, many times prophylactically, or who has abruption or who has such kind of a malady, we always start them on fresh frozen plasma as a prophylaxis. It has been studied in a few studies, yet the studies have not been analyzed properly. What is your take on this? What would be your?
Yeah, madam. In the recent days, with all the evidence available, it is not the platelets which is causing much problems related to coagulopathy. It's the plasma and the fibrinogen which does cause it, and decreased fibrinosis has been found to be a major cause of causing DIC in obstetric patients especially. So I think it is, do not mistake me, I think most of the obstetricians are very obsessed about platelets and plasma. I think it is better like we do that in a very scientific way. In the current evidence, we can see like 1:1:1 or 2:1:1, that is PRBC, plasma and platelets, or ratio of 2:1:1 or 1:1:1 is good. Even if we don't get platelets, it doesn't matter. I think administering plasma in equal with PRBC is vital in obstetric patients.
Secondly, would you give us a quick thing? Because sometimes the moment we get such a patient inside, you make a face saying that your IV cannula number is not right. The fluids that you have given are not right. We are already scared of putting into pulmonary edema, and therefore we are very restricted on fluids also. So what would be your take on like such a patient? Because I'm sure my obstetrician friends here will say, anyways, emergency Caesar, emergency case, I will definitely do a sonography or be sure where a placenta is. I think that is one very important, good or best practice. You should know before opening the patient, where is her placenta? That is one. And the second thing is about these issues, the fluids, sir. Dr. Prem Kumar.
Yes, madam. Once we anticipate any massive blood, once we anticipate any excessive blood loss, I think once the communication is there, I think any smart anesthetist will always secure secure at least 2 16-gauge cannulas in place. So central line is not always required in such patients. Having good flowing 16-gauge cannula is more than enough to manage any patient who may have such things. And always like having abnormal placenta on table, I think it may surprise most of the physicians, but sometimes it does happen. And once it happens, I think instead of panicking, I think calling the right person and having a right plan in place, I think should manage most of these patients.
Absolutely. So there were wonderful things. I'm going to come to the massive transfusion protocol once again. Dr. Dipti, what would be your call on being on guard these patients? Because you're doing a lot of sonography as a fetal medicine specialist. And then as we heard our previous speakers speaking about, looking at placenta is more important, because the moment we look at the baby, we start looking at the baby wherever it is. But looking at the placenta is more important. So now with the rising incidence of placenta accreta, followed by the fact that we have too many C-sections, what would be your guideline and what should be the best practice during the antenatal period?
I think I have to start, ma'am, with saying what you said was absolutely right, because within a span of just 4 weeks, within a month, I have seen 3 scar pregnancies. 3 scar pregnancies at 6 weeks, 9 weeks, and 10 weeks. So I'm pretty sure this is going to rise even more within 5 to 10 years. So that's where it starts with a sac location. I think even in every early pregnancy scan, the location of the sac is extremely important, more so when she's had a prior scar. Let it be even a single cesarean scar, not just 2 or 3. Even
Can I make an addition, Dipti? I would also want to say, I'm sorry for interrupting, that any patient who's undergone an MTP hysteroscopy also look at the cervix.
Any cervical trauma procedures where she's undergone a cesarean or a cervix handling procedure, I think a sac location is the first and foremost thing. I think an ultrasound makes a huge role in preparing an obstetrician and an anesthetist before they get into a catastrophic picture. I think ultrasound findings, as we had a talk 15 minutes where we were able to, it's not very difficult to identify an ultrasound. It's extremely simple, and the sensitivity and specificity is as high as an MRI. I feel that ultrasound should play a major role, and we've had instances where we have primed the obstetricians from as early as 12 to 13 weeks. We're able to see a placental lacunae in a previous LSCA scar. It's a low-lying placenta with a placental lacunae. It is emerging with a loss of retroplacental zone with vascularity. We've had those patients are primed as early as 4th to 5th month of pregnancy. And when they go in for elective LSCs at say 34 or even 35 weeks, as in if they are able to push till 35, 36 weeks, nothing like it, and they are planned with the blood transfusion, the anesthetist is ready. It's a clean case in the morning where everyone are available, where the anesthetist is available, the pediatrician, the obstetrician has a team. I think that's extremely important. And as an overlay, when you see a low-lying placenta in ultrasound at target scan, most of them, invariably, most of them do get pulled up higher at 32, 34. When the comment of placenta previa should happen only after the early third trimester and not before that. It's only called a low-lying placenta until second trimester, and a placenta previa comment should happen only in ultrasound only after the third trimester. So never placenta previa diagnosis, because once you name it as placenta previa, the patient goes on with the diagnosis and hardly there's any the comment on placenta as the growth scan goes by. So it's extremely important. As much as importance you give for the fetus, the Leica and the Doppler, placenta and cervix has to be given its true credit. And there are features which we'll be able to identify, those 4 main points which are easy to look at during pregnancy and ultrasound. And yes, you can correlate ultrasound pictures with obstetric management, and we've done many. I think Professor, I think Vijay ma'am's screen got muted. I think it's got stuck.
Madam, just one more point I just wanted to add is these days, like just 4 or 5 years back, fluid management was very done empirically. But these days, once an arterial line is in place and we have ultrasound machines in every theaters, fluid management is very scientifically based and evidence based these days. We just keep the ultrasound probe over the IVC, and we see the IVC collapsibility index. That's a very good indication whether the patient is fluid responsive or not. Another one thing which we do is, based on the arterial line, beat-to-beat arterial line, we see what is called the pulse pressure variation, through which also we guide the fluid management. So no longer gone are the days where we were managing fluids with just empirical basis or giving fluid challenges. Now what we see is only fluid responsiveness based on ultrasound and beat-to-beat arterial line pressures.
Thank you so much for keeping the thing going. Suddenly I lost my connection. And that was great. And I would like to ask Dr. Karpa, what would be your sort of, guideline if there is a placenta previa or a low-lying placenta diagnosed at the TIFA scan? The doctor says, the sonologist says that 18 weeks, it's a low-lying placenta. So what should be our guideline? The best practice after hands-on.
18 weeks, if it's low-lying placenta, I would tell the patient that, the placenta is low-lying, but definitely when the chances of that, because of the differential growth of the uterus, the chances of that going to the higher upper segment is always there. So I will keep her under watch and bring her for a scan by around 32 to 34 weeks to reassess the placental localization position. So if the placental position is again in the lower uterine segment, is at least 2 centimeters from the internal os, that time I would consider it as a placenta previa. That was very clearly told by Deepthi during the previous talk. So even if the patient has a placenta previa or a central placenta previa, I would actually sometimes before the delivery, it will be a planned delivery with all the multidisciplinary team involved, everybody in place, everybody very aware and everybody well alert, including our intensive care team, anesthetist, our hematologist team, blood bank team, everybody. Urologist, definitely, yes, madam. So then and I would do the scan myself to know where to put the scar in the lower segment, because sometimes if the placenta is just there, we open the lower uterine segment and we actually have to go through the substance of the placenta, which I really don't want. So I would like to go and do the scan. Actually, I'm very happy drawing some line diagrams in the case sheet. Usually I draw these line diagrams in the case sheet and mark the placental position and have an idea of where exactly I'm going to put the uterine incision. Either it's below the placenta or above the placenta, so that I don't want to cut through the placenta. So that is very important. So my preparation for this case is like, with the teamwork and all set and ready, including the hematologist and urologist. And I have counseled the patient. Because I'm working in a higher end center, there is also a chances that interventional radiologists can also be kept ready with the uterine catheters in place for prophylactic embolization. So everything in place, I will then only in a broad daylight, I would do the elective cesarean section.
We have a facility for uterine artery embolization, but our patients don't find it affording. So what we start doing is we apply the aortic clamps. Yeah, so we use the aortic clamps till the time that we have done the delivery, and we have the entire team, as you said, on board. And then, of course, the blood bank and everything comes into play. When should we deliver the placenta accreta? What is your take? 34 weeks, 36 weeks, 35 weeks, 37 weeks?
Placenta accreta, the patient is absolutely asymptomatic, has no bleeding, and the patient is fine, I would definitely push at least till 36 weeks with a dose of antenatal corticosteroids.
Magnesium sulfate. I will give magnesium.
Magnesium sulfate before 34 weeks. So in that situation, that will be my criteria. So in case of Acrita, if I would definitely not try to separate it. I know the sonologist would have given us the Acrita scoring, PA scoring, and if required, you would have also done an MRI to know whether the involvement, whether it's an Increta or a Percreta, and involvement of the other parametric organs, including the bladder. So everybody is all set and ready. And if I'm going to deliver such patients, I would prefer not to remove the placenta, because many a times we end up in catastrophic hemorrhage with this. So I would actually clamp and the cord after delivery of the baby, we clamp the cord and leave the placenta in situ. And if there is a massive hemorrhage, I would have already counseled the patient and the couple for a cesarean hysterectomy, and I would have taken consent for that as well, for the cesarean hysterectomy. So if things are all favorable, then I would hemorrhage is very well controlled, then I would leave the placenta in situ. Even the latest NICE guidelines very clearly says that methotrexate is not to be given, and it has no role in the dissolution of the placenta, even if it's left in situ. Most of the time, we need to follow up this patient very closely. They stay in the hospital for a very long time. Usually, we follow them for more than a week, 10 days, do a repeat ultrasound to check for the any bleeding, and also placental products can expel, which can cause infection and sometimes severe bleeding. So the management of secondary hemorrhage and sometimes the secondary hysterectomy may also be required in situations.
You know, there are quite a few people in Japan who have done deferred hysterectomy, which we have also done in our practices once in a while, wherein at that point in time, you just do a classical C-section and come out, wait, and then after 6-7 days or maybe 10 days, you build up blood again, give her antibiotics and do a hysterectomy at a later date, so that there will be less hemorrhage and less challenges. So this kind of an approach also can be considered. Recently, like 2 days back, we did a cystotomy of a patient. We removed we opened the bladder because she had a huge placenta which was onto the bladder, and then we did a hysterectomy. But of course, we require the urologist there. You mentioned, Dr. Karpa, about the PS scoring of this Acrita. Can Dr. Dipti tell us about what is this scoring?
Yes, ma'am. So we have two scorings for placental Acrita, and we call this as a spectrum. So that's why it's called placenta Acrita spectrum. And I think there are 4 major gradings. So when we see a placenta, it hardly takes like 15 to 20 seconds to look at the placenta. I think that 20 seconds is extremely crucial for the obstetrician and the anesthetist during the time of delivery. So when you see a placenta, you see the placental substance. One, and the first and foremost thing which is striking you, it has to be a homogeneous substance. That's first part. And what we score is based on the 4 findings. PA 0 is when you have a smooth placenta which is just low lying and nothing else. It is a routine smooth placenta which is low lying. It is not. It is absolutely normal. It does not have any lacunae. In a PAS score 1, you have placental lacunae. That is that. But then the retroplacental zone and the myometrium and the uterine surface, everything is normal. And in the PAS score 2, you have lacunae along with the loss of RP zone and with vascularity. And in PAS score 3, you have excessive vascularity both in the lacunae, and you can actually see the invasions of it. So actually these scorings are done to make sure that both the fetal medicine specialists and the obstetricians are in the same way. So when I give PAS score 2, the same thing is conveyed to the obstetrician as well. So that's why the scorings are made. And placental lacunae, yes, it will have a moth-eaten pattern, and it is not difficult to identify in ultrasound. You train your eye to see normal placenta, normal retroplacental zone. You cannot and you should not be missing a placental Acrita spectrum.
Absolutely. And one of the important simple messages which I speak to my students is, when there are lacunae, and whenever there is myometrial invasion, the myometrium is getting eaten off, and therefore it will not be effective. And one of the things, Dr. Karpa, I wanted to also say, you are also managing so many patients like this, that many times it is wiser not to give a oxytocic at the time of the delivery. What is your call on this? Because that causes excessive irregular separation and bleeding. What would you want to say?
See, basically, if the bleeding is well controlled, we give the routine dose of the oxytocin only, madam. And been actually sometimes our anesthesia is also not very comfortable giving high dose oxytocin because it also has a vasopressor effect. So I always give enough dose to make sure the uterus is very well contracted and not causing excessive bleeding.
Absolutely. Dr. Prem Kumar, do you also take cognizance of the PAS score that Dr. Dipti just told us? Is it important
madam.
for you?
Yeah, we have a score. We have score something with high suspicion and low suspicion score, which almost correlates with what Dr. Deepti told. So based on that, and there has been a lot of studies where they have found like MTP has been associated only with patients, at least 80% of patients with high suspicion score. And one more thing with Dr. Karpagmal actually said, which I also wanted to stress is why we are so skeptical about high dose oxytocin is when patient receives more than 20 units, they go into supraventricular arrhythmias, which is a very common phenomenon. In most of the patients in normal deliveries where we have somewhere around 20 to 30 patients does have arrhythmias, which will be usually benign, but once we go to a higher dose, it's a big problem. So having a patient with supraventricular arrhythmias and hypotension is very, very challenging to manage.
Absolutely. Thank you so much. You had already spoken to us about the MTP that has to be initiated and the contents of this MTP. What is the guidance that you would give to us? Because, all of us are not practicing like Karpa and I am practicing in big institutions. Sometimes we have our small setups where we can have such kind of patients. So how should we, because MTP is a wonderful guideline and it has to be an SOP, like what we have done in our hospital. We have an obstetrician, we have the blood transfusion officer, and we have the anesthesiologists and the physicians on the board who have decided how and who and where it is going to be instigated and activated. What is your guidance being an anesthesiologist? What should we do? Because I'm sure you must be also visiting some small nursing homes or individual practices, and there what should be the way of approach to this?
I think once we have a patient with abnormal placentation with pre-op diagnosis, I think it is always better to shift the patient to a tertiary center. And that's what the guidelines also says. And without having at least 10 units of PRPCs and or 10 units of plasma, I don't think it is safe enough to take these sort of patients in any sort of smaller hospitals. So the best thing is to do is, if there is a surprise on table, then it has to be managed. But if it is done as a pre-op diagnosis, and I think it is better to save our skin and to save the life of the patient, it is better to shift the patient to the tertiary care center.
Absolutely. So the message one more is, one of the other best practices is that you should have an MTP in place in our hospitals. Even if it's a small hospital, it's always better to go to a tertiary care center. So it's important to you to have these linkages. And we already had Dr. Dipti giving us the classification of these various kinds of things that have been looked at the placenta through the color Doppler to be able to make it correctly diagnosed. And the message that she has given us from the first trimester, from the second trimester onwards, we have to keep on looking at the various patterns in the placenta, and we cannot miss the diagnosis of PS. Is a wonderful best practice message that she has given, which can give us a window of opportunity for giving a proper antenatal care and a proper decision making with experts like Dr. Prem Kumar on board to guide us. Now, this is one case like this, which Dipti, I wanted to share with you. This is a patient who has had recurrent miscarriages, and throughout her antenatal pregnancy, they were constantly saying that it is a mesenchymal placenta. And when I decided to open her up, again, planned her nicely on a working day with entire team being ready, did a C-section at 34 weeks because a baby was suffering from fetal growth restriction. It was just about 1 gram. And when we opened her up, I delivered the baby, and I found that the entire uterus posteriorly was eaten away by the placenta. So these are such kind of things whenever you have a scarred uterus, and you can see the picture here. This was seen when the patient was 8 weeks, that there were these anechoic places where I remember, she was my sister only who was doing it. She used to say that it's looking abnormal. We showed these plates to Dr. Kindre, who is the senior most sonologist, and he said, it may be a mesenchymal disease, but maybe you be on guard. And this is what I wanted to share. There was a complete posterior thinning of the uterus, and the placenta was not at one place. The entire uterus was full of placenta in various places. So we have to be on guard in uteruses which are scarred and have to be careful. And this was my publication. And as we understand, Dr. Karpa, if you can give us the care bundle, the important 6 points for placenta accreta syndrome, what should be our approach? And then I think we will conclude this session with certain final messages from all of you. Yes, Dr. Karpa.
It's just the planning and being well prepared, madam. We should be on alert, and we don't want to be caught by unplanned and catastrophic surprises. I don't want any surprises in the last minute. So it's a planned procedure. So we have to have a senior consultant obstetrician and a senior anesthetist involved, all the blood and blood products ready, hematologist involved to make sure the blood test that we are doing, even if it's an FDP or feeding time, cotting time, everything has to be, the reports has to be available as early as possible. And it's a basically multidisciplinary planning. And before that, during the antenatal periods itself, the counseling the couple, that takes a top priority. What are the complications that could be anticipated, and what are the ways that we have actually planned to manage? And that's more, first thing is we have to tell them that we are going to involve so many people. And we have to just give them an idea that it's a major surgery and we are going to involve people. There can be complications, and we have always sorted out when we have found out ways to sort out the complications. And post-operative care is very, very important. As after surgery, she needs to have a good higher antibiotics to make sure she doesn't develop infections. Secondary hemorrhage should be avoided. Post-operative pulmonary complications. Many of these patients who have general anesthesia, so they can develop pulmonary complications. Deep venous thrombosis, and wound infections, everything that has to be taken care of. More importantly, when there is, even if there is a small time where she has had a renal failure, where there's been a pre-renal failure, shock, those things have to be managed. So I would always be on guard for all these complications, and keep the intensive care intensivist also involved in the care, post-operative care. So this is very, very important, because placenta, we always feel we have to manage the situations by being well prepared. Preparedness is the key to managing placenta accreta syndrome.
So if you are right 50 times and if you are wrong one time, that can wash off your 50 times.
Exactly.
Right. So we have to be on guard.
One person will really change the way we, our life.
Look at life and look at our practices also.
Definitely, definitely. It's one thing that we really have to be very, very careful.
So we have to not only protect our skin, but protect our souls also, because this is very, very hurtful when we lose a patient. So any last moment message, Dr. Dipti, you would want to give us, and then we'll come to Dr. Prem Kumar.
Yes, thank you so much for the opportunity. It was an excellent panel discussion. I only want to say scans cannot be done in a hurry. Never. Never. And do not compromise on anything when you do an ultrasound. As much as it can be adjunct, it should always be done in a systematic way. You need to have your checklist in mind. If you're seeing a fetus, it's not just the fetus by your scanning. There are so many other things, as in the placenta and the cervix and the liquor, which is equally important as that of the fetus. And it actually can prevent all these catastrophic things which we are talking about. And if you can actually plan a pregnancy, counsel the couple and get them to the theater, I don't think it's nothing like it. So I think we should give enough time in ultrasound. Don't hurry up on any patients. Let it be any sort of an ultrasound at any point of trimester. Do have a checklist. Give time for your ultrasound scans, and then perform with the checklist. If you perform, you will never miss anything in ultrasound. I think that's how we can help out each other.
Absolutely. Thank you so much, Dr. Dipti. Dr. Prem Kumar.
Yes, madam. I think as we discussed previously, need not wait for cross-match blood. Always need not hesitate to transfuse O negative blood, and always have a system in place to activate MTP, and never hesitate to call for help. And what I want to ask all dear colleagues is, never worry about the patient. There is always a person at the head end to save the patient.
Thank you so much for that. And we definitely are going to indulge into taking help from you more and more. And our last word, because finally the deliverables is delivered to Dr. Lakshmi. So Dr. Lakshmi, we would want to have something from you before I think you're catching lunch behind the screen.
No.
I'm teasing you. Yeah.
Sunday we have a brunch early so that the entire relax, not much of a work.
Yeah. Yes.
So as Karpagambal said, preparedness is very, very important. We are very well prepared to receive a preterm baby. Two, I spent a lot of time in counseling these parents. They have the right to know what to expect, whether this baby will live, how will the baby do in the future, how much I have to shell out. And my humble request to all the infertility specialists is to prepare the parents for receiving a limit of viability baby, and that can be a costly affair, and they have to be prepared for it. There is no point if they are shelling out 10 to 15 lakhs on infertility, and when a 27, 25 weeker or 26 weeker come, it is not right that they do not have the money to take this baby forward. So they have the right to know that yes, they can land up in a situation. So these 3 points are very, very important from a neonatologist point of view. Thank you for the good opportunity.
And one more practice that we have in our practices, madam, is I do a lot of antenatal neonatal counseling. Like if a delivery is going to be imminent, or we are thinking that the preterm baby is going to be born, or there are going to be hemorrhage difficulties, I always take the neonatologist on board antenatal itself, so that we have a counseling session that side itself. Because sometimes last moment you have to give them surfactants, intubate them, take them to the NICU. All these things, if the antenatal time is spent in doing that decision making, I think that has given a lot of valuable inputs to the patients, and that helps. So I thank all of you for having me here in Chennai with you, virtually, if not personally. And most importantly, Professor Hepzibah, who is my hero. I love her so much for giving me and bringing me to discuss such wonderful things with Dr. Lakshmi, Dr. Prem Kumar, Dr. Dipti, and Karpa Kamal. Dr. Selva Priya has become busy. She's in my own city. She's doing another panel discussion, so she has left. But with all of you here today, I want you to give a nice smile. I'm going to stop sharing. I request all of you to definitely remember me, to vote for me when I'm contesting for the White President Foxy's post. And everybody, if you can put on your screens, I would like to take a lovely picture, which I'm going to share on our group so that we can look nice. I can see a wonderful rose Dr. Hepzibah is wearing, and it's looking so beautiful. And I'm jealous. Thank you.
Thank you, Dr. Richa. That was a wonderful panel, right from preconception counseling till the neonatal counseling, what is the importance of ultrasound and how the anesthetist is, we should involve with the anesthetist. It was really, really useful, practical points. Thank you so much. And all the best for your future endeavor. Thank you. And
yes, please remember my name. Don't forget. I have to win. Yeah.
Sure, thank you for the lovely panel we had. And
thank you.
Thank each one of you from bottom of my heart.
Each one of the panelists was wonderful, and thank you for the trust, madam. Yeah.
Thank you.
It was a pleasure, ma'am. Thank you for the opportunity. Thank you so much.
For the opportunity, madam. It was very nice talking to you. Thank you so much.
Thank you, madam. Thank you for the opportunity, madam. Thank you.
Okay. Formal word of thanks by Dr. Padmashri. Padmashri?
Now, where is she? Dr. Padmashri is not seen. Yeah. She must be busy. Yeah.
The last session.
Hi,
I will be reading the vote of thanks.
Good afternoon to one and all present.
Unmute.
The vote of thanks. Last but am I audible?
Yeah, now audible.
Yes, ma'am. Good afternoon to one and all present here. It is such an honor for me to get this opportunity to propose the vote of thanks. First of all, I would like to thank the Almighty God for making today's occasion a success. No event can take shape without a leader. I extend my heartfelt gratitude to our Honorable Founder Chancellor of CIMAX, Dr. N.M. Veerayan sir, Director of SMCH, Dr. Savita Madam, Organizing Chairperson, Dr. J. Damodaran, Organizing Vice Chairperson, Dr. Chitra. We extend our gratitude to our HOD, Dr. K. Jayashree, for her support. Above and beyond, it is a great pleasure to work with the backbone of this international webinar and organizing secretary, Dr. Hepzibah, without whom this event wouldn't have been possible. and I would like to thank her for the same. I would like to express my gratitude to all the esteemed delegates of the webinar for their presence and contribution to make this webinar a great success. I extend my gratitude to our honorable chief guest, Dr. Tony Tan, to take out his time from his busy schedule to grace the event. I must thank the organizing team for working hard for the past few days to make this webinar successful. I also thank our education partner with no scans. Thank you everyone once again for making it a great success. Have a great Sunday, everyone.
Thank you. Thank you.
Thank you.
Thank you, madam. Thank you very much. Thank you.